untuk mengakomodasi PPDS. Kita tahu bahwa kita punya residence sekitar 610 dari 13 sentra pendidikan yang nantinya akan lulus menjadi seorang dokter THT dan akan ada tantangan untuk menyelesaikan masalah-masalah kanker di bidang telinga, hidung, tenggorok, bedah kepala, leher. Saya ucapkan terima kasih untuk semuanya, and thank you again Professor Francisco Bushu for attending this meeting. Hope this meeting will be fruitful and everybody have benefit of this information and knowledge. Demikian, terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Dr. Ria, for your report. And next, Professor and Doctors, we will hear the opening speech and start our webinar from the head of Oral HNS Department, Faculty of Medicine, Universitas Indonesia, Cipto Mangunkusumo General Hospital, to Dr. Ika Dewi Mayangsari, Oral HNS Specialist, Head and Neck Oncology Consultant. The time is yours. Please, Dr. Mayang.
Thank you, Dr. Uca. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon from Jakarta and good morning to our guest speaker, Professor Busu from Italia. Our Excellencies, from Professor Francisco Busu from University of Sassari, Italia. Our Excellencies, Head of Indonesian College of Otorinolaryngology, Head and Neck Surgery, Dr. Trimartani. And our Excellencies, Head of the Indonesian Otorinolaryngology, Head and Neck Surgery Society, Jakarta branch, Dr. Trijuda Erlangga, and also for all the professors, doctors, all residents, and all of the participants. As we know, today, 4th February is celebrated as a World Cancer Day in all over the globe. So we know that the numbers of the head and neck cancer cases constantly increases. And in 2000 to 2022 data, oral cavity cancer places 4th rank in Southeast Asia. Larynx and thyroid also places as the 13th and 14th rank for the new cases. And in our regional data, show that an increasement of 1.4 cases per 1,000 citizens in 2013 into 1.79 cases per 1,000 citizens into 2018, with the most frequent head and neck cases is nasopharyngeal carcinoma. So the theme for this year is still close the care gap, since we are aware that the many care gaps are still happening all around us. So we are always strive to provide a better care for cancer patients by always increasing our knowledge and also to strengthen the multidiscipline collaboration and raising the awareness through continuous mass education. So the webinar and our event today, we aim not only for the otorhinolaryngologists, but of course we make this event to our residents that who will be one of the stakeholders and one who will be find these cases and manage these cases with well management. So I believe that we all can take part in this movement. So together we can close the care gap. I would like to express my gratitude for Professor Francisco Busu for sparing your precious weekend time with us, and to the head of Indonesian College of Otorinolaryngology, Head and Neck Surgery, Dr. Ria, for providing this platform, and also thank you to the head of the Indonesian Otorinolaryngology, Head and Neck Society, Jakarta branch, Dr. Angga, for always supporting our event. So hopefully this webinar may run smoothly and we can take more advantage through the discussion. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Maya. And Professor and doctors, before we start with the first session, maybe we'll be taking pictures since everybody's still in fresh condition. Just joining the webinar, so maybe let's take a picture for, as Dr. Mayang said, our contribution for this World Cancer Day movement. So please, all of the doctors, professor, please open the cams so that we can document the present and also report it as our movement together to support World Cancer Day. Please, it will be conducted by Dr. Indra. Please, Dr. Indra.
Okay, everyone, please open your cam. There's a lot still not open your cam. We have a lot of participants today, so I think we'll be okay from Unhas, Unut, Unair. Please open your cam. UI. We have 13 pages, so it quite take quite long. Okay, please open your camera. Okay, I'll start in the 5 seconds. 5, 4, 3, 2, 1. The first page. Okay. Wait. Okay. Next one.
Sama kali. Itu kamera bawah.
Okay. Wait. This big smile. And then the next page. Okay. Okay. Then
Okay.
wait. Still some page.
Yeah, we are also reminding again to please open the camera so your present can be documented.
We have a lot of participants, so it would be grateful.
Is it already?
Okay,
Uh,
I think we can start.
Yeah, okay, thank you. It's a pleasure and really grateful that we reach more than 300 participants for this afternoon. As Dr. Ria mentioned that we have 600 residents. During the day discussion and presentation, there will be more participants that will come in and join us. So Professor and doctors, we will start the first session, and for this session will be conducted by moderator Dr. Ika Sari, my teacher, my senior, beautiful, lovely teacher, Dr. Mayang. As we know that she is the head department of Oral Hygienist Department, Faculty of Medicine, Universitas Indonesia, Cipto General Hospital. She also acts as the international speaker and also reviewer in several journals. And Dr. Mayang, she also the instructors for residents and also specialists in head and neck carcinoma. Please, the time is yours, Dr. Mayang.
Okay, thank you, Dr. Ucha. So it's a very honor for me to be the moderator for this session. Okay, so first of all, maybe is there any curriculum vitae of Professor Francisco Busu, Dr. Ucha? Okay, yeah. So let me read some of the curriculum vitae of Professor Francisco. So Prof. Busu is a director of otolaryngology residency program at the University of Otolaryngology, also in the Sassari University. And then he also performed more than 100 brachytherapy implants for the head and neck malignancy and also the he has the expertise in phoniatrics. Yeah. Okay, so and also he proposed a new classification and staging system for nasal vestibular malignancies that is currently being validated in an ASTRO, which is a study involving 42 centers from all over the world. Okay, so Professor Francisco Busu, I think it's time for you to give your presentation for about 30 minutes. And then after that, we will make a discussion for this session. Okay. Please, Professor Busu.
Thank you, Dr. Maya Asvari, and thanks to Melinda. Thanks to all the excellence that's been, and to all the participants. I see a huge number. It's more than 300 participants in this webinar, in this Zoom meeting. So it's really a huge honor. I'm happy to try to talk with you today and to share our knowledge. And it's been wonderful being in Bali for the PITO Orlia Congress in October. So I accepted with joy, and I'm really honored for the invitation. And I also appreciate the approach to this issue, to the care gap in the neck cancer. And also I see, I heard some interesting data from Dr. Maya Asvari, so I hope there will be a home for discussion in both after my lecture and during the case discussion. I start with sharing my slides. Okay, they are a lot, so I will go fast, but then I hope we can discuss more in details and issues while discussing the case and after my lecture. Okay, so we already heard what's care gap. So it's the different possibilities to be cured for different people, which is of course something we want to avoid, and it's the aim of this campaign. And it's something which it's not true only between different countries and between different areas of the world and between different populations, but it's maybe more evident within the same nations, within the same states. United States, which are our source of guidelines, or let's say somehow reference for scientific and clinical research, reported that different mortality data for the different ethnicity within the nation, which is something really we should avoid, because it's mainly not due to different, let's say, clinical issues in different ethnic groups, but it's mainly due to different access to care. So it's a huge problem, not only within the world, but within the single country. And in fact, the lack of access. Can you hear me? Okay. Can you hear me? Okay. And in fact, the lack of access to health system is one of the main problems, main issues making the cancer gap. And as I will tell you in a few minutes, it's something we couldn't personally, individually change, but we can approach individually the other issues, which I will try to quickly analyze and provide some example of our approach. So starting from the lack of access to health system, it can be, of course, due to the in the nations with the private health system. It can be due to the absence of insurance, to irregular administrative status, also in the public health system. Of course, medical doctors can volunteer in a non-profit organization trying to provide essential care to the people who usually does not have access, but it's something which is mainly a matter of policy making. And we should remind to our policymakers that recovering people and providing access to healthcare to people has a positive economic impact on a state level. But probably sometimes there are private interests and financial interests which go against this approach. But as I told you, actually, there are other points I will try to outline during my lecture, which can be addressed personally. And I think I can talk about this issue because I was trained in fancy places in Policlinico Gemelli Rome. It's the hospital of the Pope, and in MD Anderson Cancer Center in Houston. I've been working in Policlinico Gemelli for about 20 years. Then I moved back. I took a challenge and I moved back to my land, to the Highland, Sardinia, in 2017. I was 43-year-old and I got the chairmanship of otolaryngology department in the biggest hospital, the largest hospital in Sardinia, where we have big problems of, let's say, material resources, and a lot of people leave from Sardinia to be cured to northern Italy. So of course I decided to choose the less, let's say, fancy and the less advantages under an economical point of view solution. But it is a big fun because you can really make an impact. You can make even a bigger impact, trying to build a system and to reduce the care gap. And that's what I'm trying to do in my land. You see, Sardinia is a relatively small island. You have you have hundreds of islands in Indonesia. Here, exactly the other part of the world, you have Sardinia, which is a wonderful under naturalistic point of view, but it's somehow sort of ancient land, ancient society in the middle of Mediterranean Sea and in Europe, in Western Europe. And so I will try first to provide an example on how we can approach the lack of material resources in the healthcare system, which is, of course, also typical of my region, of my current situation. Your country is probably a very nice future. It's growing fast, and this lack of material resources is decreasing continuously. So it's something some of you may have to face not for a long time. But I do think that sometimes it can be sort of not a problem of offer, but a problem of demand. So sometimes you think you need something, but in surgery, in head and neck surgery, even more, easier and cheaper is better. And I will show you a very quick example of my experience with laryngeal cancer in Sardinia. This is a paper which has been just published in Journal of Personalized Medicine. You know, there are a lot of discussion about the guidelines to stage the laryngeal cancer. We don't have trained experienced laryngologists in MRI, and we have a difficult access to MRI. So we started indicating laryngeal treatment basing just upon the CT scan and endoscopy. And we don't use radiotherapy for laryngeal preservation. We usually, when it's feasible, use supracricoid laryngectomy. And we described our series from 2017 to 2021. And you see the relapse-free survival, the disease-specific survival, and the overall survival are impressive. Of course, the overall survival of total laryngectomy is lower because we have a lot of elderly patients dying for other causes. But the disease-specific survival is over 90%, which is superior than many of the so-called fancy places in Western countries. So the simplicity is better and does not compromise oncological results. You can even see that we didn't have patient loss for cancer in partial horizontal laryngectomies, in supracricoid laryngectomies. And I show you one example of this. This is a relatively big supraglottic cancer, and this is the results after after supracricoid laryngectomy. Okay, so larynx is moving nicely. He eats very well. He gained weight after recovering swallowing, which requires some speech therapies. And this is one of the reasons why we can tell that supracricoid laryngectomy can really preserve the larynx if the indication is correct. And it's something where you can really do without particular means. You don't need a radiotherapy facility. You just need your knife and a speech therapist for rehabilitation. The other message with laryngeal cancer is in total laryngectomy. So we hear a lot about free flaps, and of course they are very nice, and of course they give you an incomparable functional result in oral cavity cancer, in mandibular defect, in tongue defect, but they are very expensive because they require specific training, specific tools and facilities, and long operating time, which is of course money. Well, actually, I will show you the result we have with pectoralis major, even combining it with tracheoesophageal puncture. So we allow our laryngeal cancer patient to speak, and I will show you some cases using this prosthesis between trachea and esophagus, and we can reconstruct even huge defects of after pharyngolaryngectomies using pectoralis major, and it does not compromise the use of tracheoesophageal puncture. I have here as the preliminary series. Now we have double the case than this, because last year we had a lot of total laryngectomies, and you can see it that the pectoralis major reconstruction, when we have a big defect, is not associated to a higher rate of complication, even if we do the tracheoesophageal puncture. And also the patient with the pectoralis major use the tracheoesophageal puncture, use the prosthesis even more than the patient with primary closure. I will show you some example. These patients have a normal life. They speak normally, they speak to the phone, and they can even use a variant of the prosthesis with free hand valve. So this patient can speak without closing the hole while speaking. And using our pectoralis major, we developed some surgical tricks which can help you have the best result. I think, I don't know if in Indonesia, we can discuss about it later, you use a different type of prosthesis. Bloomsinger is the most used in the US, but we use the Provox system because it's definitely more used in Europe. I don't think there are substantial differences between the two options. The pectoralis major is a huge muscular flap. You can raise it with skin or only with fascia. And both variants have their own advantages and disadvantages, and we will try to discuss it with some example. This is a patient reconstructed with after a total laryngectomy, enlarged with a total base of tongue resection, enlarged to base of tongue which was infiltrated by the primary laryngeal cancer, and it was reconstructed with the myofascial pectoralis major. You see no difference with the patient with the primary closure. And this is another huge case of hypopharyngeal cancer. You see, this is the surgical pictures. You see the cancer, the total laryngectomy with the tumor, and the big defect with just a strip of mucosa posteriorly. We developed this technique, this reconstructive technique, putting the stitches first and then closing as a book our pectoralis major to rebuild the pharynx, the esophagus. And here you see the endoscopic image and the voice of the patient. You see the prosthesis in the esophagus, which is going to be, of course, under the it's going to be caudal to the reconstruction. And here is another example of huge reconstruction involving all the base of tongue for a tumor infiltrating from the supraglottic larynx to the base of tongue. And here is the result. Again, you see when the defect is bigger and the strip of mucosa is very, very small, we can use, this is a retrocricoid area cancer, you can use the myocutaneous variant, which gives you less retraction than the myofascial. Here is the prosthesis. And of course, when there is the skin defect, you always use the myocutaneous. You reconstruct the skin with the skin of the flap, and you reconstruct the mucosa with the fascia. And you can even reconstruct the trachea. This is an extreme case. This is a recurrence in this level 6, so paratracheal nodes of squamous of the larynx, which was previously resected with a subtotal laryngectomy. So you see the larynx has no recurrence and it's working fine, but the patient had a huge recurrence. You see here in the paratracheal node, in the recurrent node, we had to dissect it from the carotid artery and from the innominate artery, and then we had to resect a big part of trachea. Here it is, big part of trachea. So the defect was very close to the innominate artery. We decided to reconstruct the trachea with the myocutaneous pectoralis major flap. And you see here the reconstruction with the skin inside to reconstruct the trachea. And we even put the prosthesis here, you see? The prosthesis, and the patient spoke for 2 years before dying for distant metastasis. So as I've shown you, you don't need free flaps under the hyoid bone. You can reconstruct practically all the defects with the pectoralis major, which is simpler, faster, and less expensive. And this can be a way. Remember that easier and cheaper in surgery is better. It can be a way also to overcome the care gap. So you don't need always the maximum of technology, the maximum of material resources to do the best job for your patient. Again, another aspect in the care gap after lack of access and lack of material resources is the lack of training, or I would say the slow acquisition of recent evidence in practice. So we can be trained very well in some aspect where our area, our country is excellent, and less well in other aspects. So I think that sharing knowledge is fundamental to fast an acquisition of recent evidence and to allow the patient to get the best possible option for their cancer. So the message for this is, of course, travel around the world and go around to learn. The world is becoming smaller, and you can reach Indonesia from Sardinia in few relatively short time, and the same from Indonesia. Of course, every resident, everyone from Indonesia is welcome, and just contact me if they want to try to share knowledge with us and see what we do and how we do it. And again, we should remember another aspect, because sometimes we think that what we get from other places, other institutions, other countries is definitely better than what we do, and it's okay for our reality. I show you an example where this is definitely not true, and it's HPV infection. Sorry, Antonietta, c'è Cecilia qua. C'è Cecilia qua. And this is definitely true for HPV infection and oropharyngeal cancer. We all know that HPV infection is an etiologic factor for head and neck cancer, and that the HPV positive cases have definitely a better prognosis. And so now we use HPV as a parameter for staging. So HPV driven cancer are classified completely differently from the others, from HPV negative ones. And it's the only molecular marker in a national American guidelines for the head and neck cancer. So the head and neck cancer, differently from other cancer, we don't have reliable molecular markers apart from HPV and maybe from PD-L1 when we want to do some immunotherapy. So of course, we still don't know exactly how to manage HPV, the information when it comes to treatment, the intensification, which is not yet a reality for many reasons. I will try to show you one in a few minutes. But still, this is a very intriguing perspective, because you can reduce toxicity in this patient, and even after recurrence in radiotherapy, this is our data when I was in Rome, you see the HPV cases do much better. They can also be salvaged more than HPV negative, and you can even do robotic surgery in salvage. This is a case we treated in 2013. Now we go directly to the resection of the base of tongue in a recurrence from an HPV positive oropharyngeal cancer. Of course, the robot is something which requires a lot of resources. I didn't have the robot for many years in Sardinia. They just bought it a few months ago, and you see this is the wonderful result, preserving the without external approach, without a transmandibular approach, and the patient is alive and well with no disease after 2 treatments for oropharyngeal cancer, radiochemotherapy and base of tongue resection with robotic surgery for recurrence. However, the impact of HPV on head and neck carcinogenesis is extremely variable, and the rate of oropharyngeal squamous cell carcinomas HPV driven is extremely variable around the world. So in Indonesia, we don't have reliable data. We can discuss about it. You can give me your experience, but it's going to be very low, about between 10 and 30%, not higher. While in the United States now it's probably more than 90%. In Sardinia, that's one of the lowest rate among Western countries. We published a paper with only 14.5% of our oropharyngeal cancer which were HPV driven, and this will have huge consequences. Also, on the perspective of treatment intensification, still the problem of treatment intensification is that we don't have a consensus about the detection method, and it's something which is going to be very relevant in relation with the different prevalence of this tumor in different areas of the world. So we know that the best option is a 6 and a 7 detection, but it's not routine in many situations. So the current acknowledged standard is P16 high immunohistochemistry. The Americans, of course, spread their guidelines. P16 is not the virus. P16 is a human protein which is synthesized in response to the HPV infection. The Dutch guys, they propose a different approach, because P16 can have false positive cases. So the Dutch group of Brackenhoff, and I know Marlene has been trained in Holland, they are the best in HPV research. They say, okay, we consider positive only when it is P16 positive and HPV positive. Because when it's P16 negative and HPV negative, the prognosis is as bad as P16 negative. It means that if we intensify the treatment in these cases, basing only upon P16, we are going to do an under treatment. And of course, this is a risk, much bigger risk when the P16 false positive cases are more numerous. They are 12.4% in Holland. They are much more in Sardinia, where we have the same problem with the prognosis, and we have 25 to 33% false positive cases. So almost 3 times the Dutch and probably 20 times the American or the Scandinavian rate. It means that the highest, the prevalence of the HPV-driven infection in a given population, the lowest the rate of false positive P16 immunohistochemistry. So in the US, you have a very high rate of HPV-induced oropharyngeal carcinogenesis. You can use P16. But in Sardinia and in Indonesia and in many parts of the southern world, the rate of HPV infection in the oropharyngeal cancer is lower than 30%. So the rate of false positive is too high to recommend treatment intensification. You will kill your false positive cases. So it's an example on, this is another paper published with a clear formula to predict the rate of false positive P16 high immunohistochemistry. So the model of the US using P16 to predict the HPV-driven carcinogenesis is not applicable to the rest of the world. So everyone needs to work with its own reality and share knowledge, but not accepting without any criticism the models imposed by different countries with different epidemiology, with different situations. And of course, this is it has made P16 a trap. So it's been so fancy and the old guidelines, but in our reality, it's not reliable at all. Again, the last example I want to give you is concerning the lack of confidence. So the cancer care gap in when we see it from the perspective of physicians may derive from a lack of confidence. So you say, okay, I'm living in Sardinia, working in a low income area. I don't have means. People is leaving to be treated. So we can't do more. Well, I show you an example where it's clearly not true. The last year, Sassari, my facility, has been the first center in Europe for nasal vestibule carcinomas. We publish a lot. We have a monography on Springer, and somehow we put Sardinia at the center of that scientific world, because I will show you fast now, we are changing the standard for nasal vestibule. So there is, I told you, a high number of patients leaving the Highland to be cured, but this year we got most patients with the nasal vestibule carcinoma from the northern, richer part of Italy. Our colleague referred them to Sassari to be cured from the fanciest and richest places in the northern Italy. We treat all nasal vestibule cancer with brachytherapy. That's an historical image. It's an old technique. Usually they put the radioactive source in the tumor, but of course it became obsolete with the new external beam applicator, also because you had a lot of exposure for the operators, for the visitors, and a lot of dosimetric issues. But then modern brachytherapy changed. So we have now remote afterloading. We put the source, the radioactive source, in a bunker, in a cage, protected. Nobody is going to get undesired radiation. And from this bunker, the source is passed through this. This is a case of nasal vestibule. It's passed through these tubes, and deliver a very high dose, and this dose is very precise because we can control the time of transit of the source in the tube and design very precisely the dose on the CT scan, on the images. And how was it possible that Sassari became the first center in Europe for nasal vestibule carcinoma? Well, it started in 2010 when I was still in Gemelli. My friend Vincenzo Valentini is my chairman, Professor Palodetti. They sent me over to Lübeck, where there was the last radiation oncologist able to perform a brachytherapy, because before the new technological advancements, it has been abandoned. So we treated the first case. It was actually an adenocarcinoma of the ethmoid. The other cases, which were recurrence after surgery and after radiotherapy. Of course, the prognosis of these cases was bad, but of course, we prolonged their survival, and we even had some long survivors. But I started thinking about a different scenario. I started thinking about the nasal vestibule, about the tumor, which require most often resections, which are very difficult to reconstruct, and we should not affect our approach. The reconstruction is extremely difficult. This is my book, and I asked the best reconstructive surgeon in Italy to show that the reconstruction was very difficult, unreliable, and the best option is to preserve the cartilaginous framework in this tumor to avoid total rhinectomy, because it's very easy to notice the cosmetic problems in the nasal vestibule, and the cartilage is very thin, the skin is very thin, free flaps are too much, local flaps are not enough. And when you take out a nose from your patient, you are killing him. The Eastern Romans used to cut the nose to their enemies to avoid killing them, because under a social and a political point of view, it was like an homicide. And there is only an example of a man who came back from this hell, from this definite social isolation after rhinectomy, which is the Emperor Justinian. And in fact, the prosthesis allowed him to retake his throne, and the prosthesis is probably the best option in these cases, in the total rhinectomy defects. And we wrote also a chapter on this in our book. But of course, we should avoid it. And that's why I thought that nasal vestibule was the perfect situation for brachytherapy, because we can easily implant the tubes. We can go very high with the dose because there are no vital structure to preserve, and the cartilage, under some conditions, is very resistant to radiation. But I discovered, when I had this idea in 2011, that the Dutch guys, they were already doing this, and they had a relatively big series to present at that time. It was this is a paper from 2006. So it was my idea, but somebody had it before. So I went to my friend, he is very, very good cosmetic surgeon of the nose, Alberto Artuso, and complained with him, well, I had this idea, but the Dutch already had. And he said, okay, don't worry, you can still do it. And after a few days, he brought me this patient. She was 81 years old. Now she is 93, free of disease. You see, this is the tumor. This is the implant. This is the complete response after many years. And when we did this first case with Alberto Artuso, he's a wonderful surgeon. He does a lot of rhinoceptoplasty. We changed the approach. So we decided that our plastic tubes should ideally not violate the planes of the nose like the Dutch did before. So the Dutch recorded a lot of holes in the septum and in the ala, because if you pierce the perichondrium also while doing a septoplasty, you will have a hole. But if you don't pierce the pericardium, if you respect the planes, which are the planes of septoplasty and rhinoseptoplasty, you will have perfect cosmetic results. You will have a preservation of the cartilage, and so a preservation of the cosmesis of the nose, which has not been destroyed by your tumor. So the Dutch, they started doing brachytherapy before us, but then we taught them how to do brachytherapy, how to make the implant without any septal and alar perforation. I show you some cases while I was in Rome. This would have been a total rhinectomy defect, a young guy with his nose in place and without tumor. He was healed, he's still alive and well. Again, columella. So we published the first paper, and the satisfaction of our patient treated with brachytherapy was incredibly high, and definitely higher than surgical patients. Then I went to Sassari in 2017 after this experience, and I found that the machine was there, but wasn't used. Okay, it's a pity, that's a spoil, but still I didn't give up. So I had some patients referred from all over Italy. Here it is. This is a case with the tumor infiltrating skin, as it often happens. I will show you in a few seconds again. This is a huge case, total rhinectomy enlarged to the bones and to the superior lip. This is the results after brachy. We published many more papers. And finally, after going to Rome many times to treat my patient, after coming to Sardinia, I found my friend from the first case. And one of them, Giancarlo Macchiucci, moved to Mater Olbia in 2022, and we started doing the implant and the treatment in Sardinia. So I implant my patient in Sassari, and they do the irradiation in Mater Olbia. This is the first Sardinian case, and in 2023, look at this, is impressive recurrence treated by plastic surgeons many times and cured with brachytherapy. And last year, young lady with the tumor infiltrating the skin. Again, young man with the big tumor on the columella. Ala of the nose. These are all patients treated the last year in Sardinia, referred from northern Italy, mainly from Milan and Padua. Again, this is from Rome, still treated this year, big columella cancer. And this is a young girl. This is the youngest. She's a musician, 26-year-old, with this huge nasal vestibule cancer, which would have required total rhinectomy, treated with brachytherapy with some skin scar. We are now treating with laser. Complete response, avoiding total rhinectomy. Can you imagine the impact for a young girl, a musician, playing in an orchestra, of resecting her nose? This would have been the end of her life. And then people started to invite me to show the technique. So we treated cases in Bologna, and now they are starting to do it themselves. And we saw that the oncological results are even better than surgery. So this is our relapse-free survival, and this is a surgical case, a surgical series from Italy, just published in the last weeks. So clearly better survival, not only preserving the cosmesis, but also saving the life to more patients. And then with this experience we are accumulating on nasal vestibule, we can demand the change of the standard. The first change we ask is to define the nasal vestibule, which is not defined by WHO, and the easiest anatomical boundaries we can propose is the plane tangential to the piriform opening. So we should consider everything anterior to the piriform opening as a nasal vestibule, and this is the enlargement of the area we propose. Then we described how these tumors spread mostly to the skin from all the walls of nasal vestibule, following 3 clear highways. The most typical is the nasal valve between the alar cartilage and the lateral cartilage. This brings to two problems. One, these lesions go directly to the skin, and they are sometimes diagnosed as skin cancer and mistreated, and it can become a disaster. And also, they are underestimated, because if you consider them as skin, you are not classifying them as vestibule. And even if you want to classify them as vestibule, you don't have a specific topographic code. So we demand that WHO defines a code specific for nasal vestibule. This is completely different tumors, and this very early skin invasion also brings you to see that the current TNM is inadequate, because following the current TNM, this lesion would become all T4. So we proposed a new staging system, which is currently being validated by 42 centers all around the world, but we also check the redistribution of the stagings among our cases. So with the whole system, they were all T4A and some T1. With the new system, they are distributed among all the stages. And we also check this distribution, merging our series with one of the Dutch group, which first started with this brachytherapy on nasal vestibule. The ones I saw in 2010, 11, when I discovered that somebody already had the idea. And we also checked with the same Dutch group that this proposed staging system gives you a much better prognostic prediction than the current AJCC TNM. And also we obtained the acknowledgement by the Italian Society in the new guidelines. So we got the acceptance of a paper where we define a new standard by the Italian Society of Otolaryngology, which accepts all the above proposals. So in conclusion, from Sardinia, we show to the world that the nasal vestibule is the most common nasal and paranasal malignancies, which deserves its own topographic code, that we should also always look inside the nose when you have a lesion around the nostril, and that the staging of this tumor must be changed to fit the peculiar clinical features. And also, surgery remains the mainstay for treatment of the neck, because neck metastasis is the most relevant cause of failure in these lesions, but brachytherapy is the new standard for the primary lesion, using the anatomical implantation we described following the planes of the rhinoceptoplasty. So that you see is Justinian II with his nose slit. It should never happen again in our patient with nasal vestibule cancer. So probably I went a bit over my time, but I tried to show you that which are the main reasons for, or some of the main reasons for the cancer care gap, and how we can try individually in our clinical practice to address each of them. So the lack of material resources can be addressed by looking for easier, which are most often better solutions. So treating our patient even better than those with the high availability of technology and means. The lack of training can, or most of all, the lack of sharing of knowledge and the acquisition of recent evidence in practice should be overcome with a lot of exchange, traveling, learning, stealing and bringing home. So you are absolutely welcome to Sardinia. The attempt to import from different realities, concepts and models which do not fit in ours should be avoided by being always critical and assessing the international guidelines before adopting them and building our own evidence. And finally, the lack of confidence must be overcome, because we should always remember, if there is less, you can build more. If there is a desert, you can build a huge metropolis. And so you have to enjoy the opportunity. Thank you very much. This is my book. I can share you some material, of course, if you want, and I'm completely available, of course, now in the discussion and in the case discussion, but also later you can contact me by email for question, for visiting, for consultation. I'm completely available. I'm a friend of your country. I'm grateful for the invitation, and I had a very nice time there. Thank you very much.
Hey, thank you very much, Prof. Busu, for the nice presentation and also for the invitation to come to Sardinia. I believe that all of us here are willing to go there. And yeah, it's very interesting that that you move from one area to the Sardinia, which is the low income area, and you can answer all the answer the challenge, all of the challenge that you found there. It's very interesting, including the employed the brachytherapy as one of the treatment for nasal malignancy. So yeah, there are many question here in our box. Maybe the first one I will give the opportunity to Dr. Joshua. Since there are many questions here, maybe you can ask directly to Prof. Busu. Please, Dr. Joshua. Dr. Joshua is a resident from University of Indonesia, Prof. Please, Dr.
Thank you, Prof. Thank you, Dr. Mayang, for the opportunity. It is a very interesting presentation, but is there any some question that I would ask to Professor? The first is in your presentation in laryngeal squamous cell carcinoma with a staging T3, N1, and M0, M0. After surgery, but total and partial laryngectomy, you didn't given any adjuvant like radiation or chemoradiation, Prof.
Yes. Yes. That's
Is there any reason why you didn't perform? Because as we know in from NCCN, for T3, N0, and N0 and N1, maybe we must give radiation. We look the pathological like adverse feature, so we can give adjuvant therapy. And the second, if the patient get radiation, we plan to get radiation and chemoradiation. How the time, the right time to placing the voice prosthesis after radiation or before radiation, can we can install we can placing the voice prosthesis. And is there I would ask all of my question, Dr. Mayang, or one by one?
maybe, one by one, and then the other residents will also have the opportunity to ask them. Yeah,
And
thank you.
Okay.
and the last maybe because one of the complication is partial or subtotal laryngectomy is aspiration. How to manage the aspiration, and if post-operative the patient got aspiration, what the next plan for this patient? Thank you, Professor.
Thank you.
Thank you very much for your question. I saw that you were I see that you are very interested in laryngeal cancer, and it's good. And of course, in our institution, in our area, is the most common head and neck cancer. So as for the T3 and 1, actually in the glottic cancer, we consider the adjuvant radiotherapy optional. So it depends on the age of the patient, but most of all, it depends on the other adverse features. So if you have no other adverse feature, negative margin, only one node, no extracapsular spread, and one, you can decide, or our attitude is to decide you can propose the patient the alternative, and you see there are many times difficult logistics. So the patient, if you give not to do. So in N1, T3, N1, I think we can still consider radiotherapy optional and to be decided case by case, also basing upon patient preference. Of course, if you have adverse features, including multiple nodes, extracapsular spread, which becomes, of course, an N3, or the perineural invasion, perivascular invasion. If you have some adverse feature, of course, the balance shifts towards the adjuvant radiotherapy. The second problem, you asked me about times, maybe in relation to the reconstruction. I can tell you that the healing time after pectoralis major reconstruction is no longer than primary closure. So you have usually after reconstruction, even with the prosthesis, in the beginning, let's say 10 years ago, there were some concern about putting primarily a voice prosthesis after reconstruction, or doing radiotherapy with a voice prosthesis, or doing radiotherapy after reconstruction. With these tricks we have developed with our approach to reconstruction, that the healing time after surgery is about the same. So they start swallowing liquids after 7 to 10 days, exactly as the primary reconstruction after total laryngectomy. They can use their prosthesis, they can do their radiotherapy. So according to guidelines, in adjuvant setting, you should start the adjuvant treatment 6 to 8 weeks after surgery. You could, our patients are eating everything after total laryngectomy, of course. After 3-4 weeks, they are home after 2 weeks, so they can start their radiotherapy. Surgery is not going to be an issue for the initiation, for the start of radiotherapy. We should be started according to the guidelines between 6 and 8 weeks after surgery. As for the second question, which is the supracricoid laryngectomy, of course, the main issue is swallowing. So it's aspiration. And I can tell you there are, of course, technical tricks. You need the speech therapist, and I told you, so a good speech therapist with the confidence on the matter. So you need to help them, her or him, acquire experience on the matter. But I can tell you the supracricoid, when in the long run, is much superior to radiotherapy, because supracricoid, you do the surgery, you reconstruct with the cricohydopexy, with or without arytenoid, with or without epiglottis. You just need one arytenoid, functioning arytenoid, to do the supracricoid surgery. And afterwards, sometimes, of course, age is a limitation, but you read in the guidelines that you need to operate only patient under 70. I did supracricoid laryngectomies in 78, even 80-year-old patient, of course, explaining them that they may have issues with swallowing and with aspiration. And of course, in these cases, I am expecting a longer time to recovery for swallowing. So I'm doing a PEG primarily, which usually you don't need, because most of these patients under 70, they swallow within 2 weeks with a good speech therapist and with some tricks during surgery, which will be fun to share and to discuss together. For example, being very careful in the PEXI, doing the tracheotomy very low to bring the residual larynx very high, and sparing when possible, because we can do supracricoid even in T4 with a small invasion of the thyroid cartilage. I will tell you soon when you can't do it. So but if you can, you preserve the prelaryngeal muscle and you close them over the reconstruction to limit the emphysema, and you place the suction drains very well, very carefully, avoiding to bring them air from the reconstruction. So this fasten healing times and even functional recovery. And of course, you have to try to spare the superior laryngeal nerve, which is not always possible for supraglottic cancer like the one I showed. Of course, this will fasten the recovery because they will have sensitivity in the larynx. The big issue in supracricoid, and I really want to tell my experience and what I see every day in Italy, because probably we are the ones in doing the highest number of supracricoid laryngectomies. It's something which is being popularized again by Italians. The Americans, they always do radiochemo for organ preservation. But there is a warning. So the good thing is that after they start eating and recovering and their function, they will improve. So after a subtotal laryngectomy, supracricoid laryngectomy, 20 years later, the patient is fine. Okay. After radiochemotherapy, 20 years later, the patient had definitely worsened, and probably many of them will not retain their larynx, or anyway, we will need the PEG because the swallowing after radiotherapy is worsening continuously, year after year. And that's, I think, common experience. But you must be very careful in these cases with the indication. So every posterior invasion of your larynx going paraglottic. So if you have a deep invasion of the paraglottic space, posterior, going towards the arytenoid, if you have any doubts about arytenoid mobility, then no, because the recurrence after supracricoid is not salvageable. So after radiochemotherapy, the recurrence is most often salvageable. You do a salvage total laryngectomy, okay? Sometimes you have a fistula, sometimes you not. But anyway, you can recover the patient. You can salvage the patient under an oncological point of view. After a supracricoid laryngectomy, the recurrence is almost always unsalvageable. Almost always your patient will be lost. So you need to be very careful with the indication. You should prefer anterior tumors. If you have any suspicion the tumor is going behind, especially the paraglottic space, that's a highway to the esophagus. So when you have the recurrence, the patient is lost. So perfect solution, if the indication is correct, is definitely preferable, in my opinion, and you see I'm quite convinced about this, than radiochemo. Your patients are going to be happier and to have a higher rate of preservation of the larynx.
So you don't recommendation the partial or subtotal laryngectomy if we plan to give chemoradiation, Prof.
No. That's something I learned. That's something we discussed in Italian meetings. So there are many Italian surgeons. They do supracricoid and radiochemo after. I can tell you that functional success of supracricoid laryngectomy with adjuvant radiotherapy is close to zero. None of them is going to swallow properly. So if you think you will need adjuvant treatment, also, for example, if you have involved nodes, if you have N+ at diagnosis, then you can't. I think it's useless to perform a supracricoid. Okay, and that's something actually the Americans are right. So the MD Anderson, they never do radiotherapy, adjuvant radiotherapy after supracricoid. If you have a positive margin, if you need to do adjuvant therapy after a supracricoid, they ask you to complete the laryngectomy first. And I think it's wise. Now, this is a perfect operation, but must be one shot.
Yes, thank you very much, Prof.
You're welcome.
Yeah. Thank you very much, Professor Busu. It's a very interesting discussion here. And there's also a question from Aris that asks also about the Provox or the implant devices. If we don't have any devices for voice rehabilitation, so may I know your experience to
Yes.
overcome?
Yes. Actually, That's something also I brought to Sardinia from Rome. These are we make a tracheoesophageal puncture at the end of the operation. Can I show you the previous slide so I can show you some of the cases before?
Yeah, sure.
Okay. Can you see it? Hold on. Can you see the slides? No?
No.
No. Okay.
Yes.
I go to the, okay. This is the tracheal case, which is actually the most complex. Oh, okay. You see here. You see the opening of this is primary implantation. So the Provox valve is a sort of valve with two rings, one in the esophagus, one outside, keeping the valve in place. Here it is. This is the ring. So at the end of the total laryngectomy, we make a puncture here from the trachea to the esophagus, and we pass this valve, which is between the trachea and the esophagus. And it has something which, being a valve, when the patient pushes the hair inside, it vibrates like the vocal folds and produces the voice as you heard here. You see, this is the ring outside. So it's kept in place with the two large rings, one inside the esophagus and the other inside the trachea. And the area is pushed inside the valve and produces sound. Here you see. You see? So they don't need the electrolarynx, they don't need to learn a rhythmophonic voice. And some of them are so good that they can speak with a valve in the tracheostome. So this hands-free valves, these hands-free valves allow the patient to push air against the valve. When the flow is very high, the valve closes and the air is pushed in the prosthesis. Okay, and so the voice is produced without closing the hole. Not all the patients are able to do that, and of course they have to be careful, because if they exhale too fast, then the valve closes, so they may have problems in breathing. But when they are sitting down, calm with their family, it's fine. It's nice that they can speak without closing the hole. So it's really a major improvement. There is of course some financial issues, because the cost of this Provox valve, I don't know the cost of the Bloom-Singer, which is the American version. In MD Anderson, they only put Bloom-Singers. In Italy, we only put Provox. The problem is that each valve costs about $400, 400 euros, which is the same, and that it has to be changed. Usually, it's very variable, because some patients get mycotic colonization of the valve, so they need to have it changed after 2 months or even less. Other patients can keep the valve for 18 months without needing to change. Usually we change it only when it doesn't work anymore, and it doesn't work anymore when the valve is colonized by fungi. Okay, but of course, on the average, is 4 to 6 months. So it means that you need 2 to 3 prostheses per year, which is $800 to maintain the ability of the patient to speak with the prosthesis.
Okay.
Which is can be a problem. Actually, as always, I do believe that in different realities, these prostheses have a different cost. So the companies, they try to have the highest advantage economically from a prosthesis. So they see that in Italy they can obtain 400 euros for each prosthesis, and they ask 400 euros. Probably
Yes.
because the cost of it's a silicone, so it's really nothing particularly fancy under a technological point of view. But of course, it's there is a patent on it. So the ideal to close the gap would be to say, okay, I don't care about your patent. I produce it on a public level, and it will cost 5 euros each.
Yeah. Thank you, Professor Busu. Here the Provox is very costly here, so not all the patient can afford it. So some of the patient here, we train the patient to use their stomach to produce the voice. So that's the things that if the patient cannot afford for the Provox here. So maybe the next question is Dr. Malinda, or from USU first, Dr. Unsri first, Dr. Malinda?
USU first.
Unsri.
Yeah, Unsri first, I think.
Okay. Yeah, maybe the residents from Unsri, you can ask your questions. Dr. Mutiara. Please, Dr. Mutiara. Okay, let me read the question. What is the primary indication for a total laryngectomy, and what condition or disease might lead to the need for these surgical procedures, Prof? Okay, that's the question.
Total or supracricoid? Total.
Total.
So let's say the absolute indication to total laryngectomy is T4, even if I would be less extreme, because some T4 with the limited all anterior invasion of the anterior commissure without nodes, I can actually do safe supracricoid, but in general it's T4. It's of course a recurrence after radiochemotherapy, especially if it's not treatable with partial laryngectomy. And of course, partial laryngectomies after radiochemos are feasible, but you need special considerations. So you need to be even more careful than in primary cases. And then there is the big problem. Of course, T1 and T2, I wouldn't say there is an indication to total laryngectomy, because you can do usually you can do partial surgery or radiochemo. The big problem is T3, because T3, if you want to preserve the larynx, you will need radiochemo. And as I told you before, in these cases, you have a laryngeal preservation rate. In the literature, they talk about 70%, but it's bullshit. The reality is probably 50–60%, maybe less. But the big problem is that when you preserve the larynx, this is going to work fine probably the first years, but it's going to worsen progressively. So if you read the guidelines, T3, you have the indication to radiochemo and to reserve total laryngectomy to the salvage. I tell you that in T3, when you can do a supracricoid and you don't have nodes, then you do a supracricoid. But if you can't do a supracricoid, you should talk very honestly with your patient. So tell him how important is it for you to preserve the larynx, to avoid the hole. Because remember, you may need the hole anyway for recurrence recurrence or for functional failure. So according to guidelines, T3, you have mainly the indication to, it's not feasible, you go for radiochemo. But my view is that most of these cases may live better with the total laryngectomy, maybe with the voice prosthesis, especially in the long run, than after radiochemo with a lot of functional issues and all the long-term toxicities of radiochemo. And also, if we read the Anglo-Saxon literature, and if we see the American statistics, we see that laryngeal cancer is the only malignancies in human with, together with the uterine corpus, they are the only malignancies where we did not have a prognostic improvement in the last decades. And one of the reasons is probably the strong push forward the organ preservation. So the anxiety to preserve the organ probably contributed to this failure. So the larynx has the same prognosis, even a bit worse than 40 years ago in the US. And this is probably, at least in part, due to the strong attempts to preserve the organ. With the prosthesis, with the valves, with the head and moisture exchanger, the life of the total laryngectomized patient is not, is probably better than the life of the patient treated with radiochemo for laryngeal cancer, I do think.
Yeah, thank you, Prof.
Right.
Yeah, answer I think is clear enough. Yeah. Okay, so because of the time, I think we still have time for one question, and then the last question, maybe Dr. Marlinda want to ask some one question, not some.
Yeah. Thank
One
you,
limited time.
Thank you, Dr. Mayang. So nice to have you talk, Francisco. So I have to call you Professor Busso because it's really interesting to hear your talk. But first of all, I would like to I agree with you about the late effect of the chemo radiations. And then because of what? Because you said that for the 5 years, and maybe after the surgery, after the chemo radiation is much better. But for the long term, we have quite a lot some patients with the after the surgery and then chemo radiations, and then they have a stricture of the esophagus. That is one, and that is an important thing, Prof, because I think, for the voice prosthesis, I think we learned from the Netherlands Cancer Institute about the Provox. But you know, the price in Indonesia is around $500. And then we have to still import from, because we don't have any distribution here. But we did the math support procedures by doing the posterior tracheal flap. We associated with the sphincters of the esophageal muscular wall, but it's work. But if there is a leakage or the fistula, and then we can insert the Provox. That is the things. But I would like to ask you, this is the important thing, because this is mostly the residents. And then you said there is a lack of the confidence. Yeah, there's also the lack of the confidence. So you are the experts. You are working in the very fancy. And then also you came now to the Sardinia. But what is the tips for the residents to keep the confidence and then increasing the confidence? We know that the young would like to running and then doing everything and then make money a lot. But can you give the suggestions or the take-home message for the young that how to increase the confidence and how to increase the learning process to be a good head and neck or to be a good ENT specialist? That is one, I think. Thank you, Professor, that we can discuss another time in the second round. Thank you.
Thank you. Thank you, Professor Adam. Thank you, Marlinda. That's a great question. And well, as the right man, I mean, I will tell you something about confidence, but about making money, my wife says I'm a jerk. So I really don't care about money, and that's why I moved to Sardinia. But when it comes to confidence, well, I think that the secret is to gain confidence. You need to be good, and to be good, it's a sort of it's not easy. And to be good, you need to always ask what did I do wrong. So and be curious, look around. Don't accept what is presented to you as evidence, as acquired, without criticism. So and to be able to do this, I think my suggestion is again to go around also in your own country to share experience and to always ask yourself, should it have been better? How can we improve? Am I sure this is the right way to do this? And so always the curiosity, never stop, always move. You said the young people always want to run, and I tell them, keep running. But while running, if something goes wrong, always ask yourself where you made the mistake, where you find the obstacle, what's wrong, how can it be improved? And always ask why. And that, of course, I think the history of nasal vestibule is quite an example. So I do believe that in 20 years, probably less, probably 10 years, nobody will operate anymore primaries of the nasal vestibule in the classical way, because interventional radiotherapy actually is a combined treatment, and there are surgical principles in the treatment modality. So it's really multidisciplinary, interdisciplinary approach. But all these achievements, all these discoveries, small discovery. So to see where these tumors go and why they immediately go to the skin, it's really only a matter of curiosity. Check the anatomy again, see what you see in the operating room, check your MRI again, always ask questions. And I think this way you can become always better. You can have a big satisfaction, because the big satisfaction in our job are patients. And from this, confidence comes. And when you see what the other do and what the other tell, never, always be critical, always be skeptical, always ask why. And I think that's the suggestion. And of course, if you are able, if you have the opportunity to go around the world, as we did, so you were trained in Holland, I was trained in the US, and we also worked in our places. Of course, this is one more opportunity and one more resource.
Okay. Thank you, Professor, for the answer. Yeah, I think it's time for us to close this session, Prof, because we still have another session that is the discussion of the cases. So one thing that I would like to stress about our discussion in our session is how to address the cancer gap. And one thing is we have to try to look for the easier one. That's right. And then be always critical, and before we adopt the guidelines, we have to try to build our own evidence here, so it will fit with our needed here. Yeah.
Exactly.
And then and then the other thing is to overcome the lack of the confidence. We have to learn and learn and learn. We have to learn a lot. So we have and always increase your management for our patient. Yeah, I think that's the one that we can take out to our home for this session, Professor Busu. Thank you very much. And then we will move to the other.
Dr. Mayang,
Yes, Dr. Ria.
hi. Can I have some few words to Professor Busu?
Sure, please.
Hi,
Before I-
Professor Busu. I really enjoy your talk, and I think you're a very humble person, and of
Thank you.
course also patient, determined, and also passionate about your work. So that's
you.
why you move from a very fancy hospital and then to the place that you are now, and then I think you devoted yourself to your work, and I think it is true that nasal vestibular cancer should have a new stage, because I often have referral from Dr. Ika Mayang or Dr. Malinda with a total rhinectomy, sometimes a facial lectomy. Then I have to reconstruct, and then definitely it's true, it's very difficult. Although we still have this ancient type of reconstruction using a forehead flap. I noticed also your friend from Bologna, is that Dr. Ignatius Tasca with you?
No, there was Livio Presutti, and from Bologna is the very well known Italian surgeon, the next surgeon, and the other is Gabriele Molteni, who is the new chair in Bologna because Livio Presutti just retired, and the third is a radiation oncologist who was trained in brachytherapy but never did it in the head and neck. So we did the first case together, and we did one more 1 month later in May. Yes,
Best regards.
Livio Presutti.
Yeah.
But many of you maybe probably know him because they did a lot of course about endoscopic ear surgery. So they are known yeah.
Yeah, I know Professor Ignacio Tasca. He's a rhinologist.
Yes.
Yeah.
I know him as well. Yeah. Yeah.
Something about our resident, Prof. I know that we have about only 8 semesters to become ENT surgeon, and I think that is not long enough time to learn, because there is
Yeah.
a lot to learn, not only from the aspect of the patient, but of course the aspect how to manage the patient with limited resources, as you mentioned, limited of technology, limited of resources, limited of manpower as well. And I think some of them, of the residents, have doubt about their future. That's why Dr. Malinda mentioned about how to get money. So I think
Yeah, I know. But that's the same everywhere.
Yeah. So if you can say some words of wisdom to encourage all our residents here who has joined us to be persistent and still learning, and make the learning curve shorter by doing always reflects our result of surgery before and after surgery, that you can learn what your mistakes are, and of course always be curious of any challenges, then have a passionate into how to answer all the challenges. Please, Professor, I think all the residents would like to hear from you.
Thank you. Well, of course, it's a great pleasure, and I completely agree. And thank you very much for your very nice words. Yes, the secret is work. I think what I saw in your country is much better than what I see in mine. So there is you are growing fast. You are you have a better perspective than we do have, and so I think, and also the other aspect of the acquiring confidence, that it's sort of a big challenge to exploit this time, which may seem too short, but all you do now, all you acquire now, is like a big, let's say, amount of money in a bank, because you are capitalizing on your building knowledge. So never give up, never make a step behind, always a step forward. This is something to do, you do it. If there is something to work, you work, because that's the time, that's the moment. You have exactly because you have apparently not enough time, exploit every second. Never complain about working, never stop working, never give up, keep doing, keep working. And again, always being curious. And if you have something you don't see clearly, if you are not convinced about one patient, if you don't know why it did well or why it did bad, go and check again. Check the CT scan, check the MRI, check the clinical history. So you are, I mean, your age as a resident is the biggest fun, because you are growing so fast as your country. And where there is nothing, as I told, it's much more challenging and funny to build. So build, and to build you need to work. It's hard work, but it's fun. Of course, if you do it because you have to do, it's going to be harder. But if you have fun from what you are doing, everything is going to be funny.
Thank you, Professor Puso. So for all the residents, now is the time to invest. Invest your knowledge, invest your strength to build, and then be curious. Thank you very much, Professor Puso.
Thank you. Thank you.
Thank you, Dr. Yes. So I will give the time to Dr. Ucha as an MC to continue this session. Thank you very much. Keluar suaranya, Dr. Ucha, you're still in mute. No, I cannot hear your voice, Dr. Ucha.
Yes. Can you hear me now?
Yes.
Okay. Sorry for a little bit technical problem. Thanks again, Prof. Usu, Dr. Marian, Dr. Linda, and also Dr. Ria, for also a little bit encouragement for our residents in what we have to plan for our future and for the next sessions. And also sorry for several residents, maybe that you have raised question, but we have limited time to discuss it. As Dr. Linda said, maybe there will be next round, next session with more intimate time with Prof. Busu, so you can ask more questions in that session. And we still have one more session, which is the case-based discussion. And for this more exciting also session, we'll conduct by moderator, my lovely teacher, Dr. Marlinda. I think everybody already know Dr. Marlinda, but this is my obligation to write a little bit about her CV. Dr. Linda got PhD in Netherlands. Right now, Dr. Linda is the Chief of Oncology Division in Faculty of Medicine, Universitas Indonesia, ENT Department. She is past president of ASNO, also active as founder and director in ASEAN Head and Neck Dissection Cadaver, also Head and Neck Network, and also Head and Neck Training. She also board member of IFNOS, ASNO, and APTS, and she also awarded as the Nickel Jebat Humanitarian Award from EEO HNSF at 2019. So Dr. Linda, please, the next session is all yours. Please, Dr. Linda.
Yeah, thank you very much, my sister Ucha, the rising stars of the oncology. I think I'm happy to have the new young staff, Ucha and Indra, to help our working and more relaxed. So. Thank you, Dr. Ria and Dr. Mayang, for the first sessions. And that now we have, as I told you, after the very interesting talk of Professor Busso, and then he also invite all of you who would like to learn more. And then we have 3 cases already discussed about, and then from the Palembang, and the second one from the Udayana Bali, and the third one from Airlangga. Surabaya, the east of the Java. So it showed the difference area why we would like to share the how we treat the patient, and then we learn about the how to closing the gap among the area. So Ucha, the panelist is also, I would like to, of course, we still have Professor Busso. I hope that you are still eager and still has a spirit to stay with us until the next 1 hour. And then after that, you can get the cappuccino and the spaghetti bolognese. And then the panelists also, our lovely chair lady of the ENT College, and of course we have from East Java, we have the new fresh Professor Dr. Muhtarum Yusuf. Welcome, Prof. Muhtarum Yusuf. And also we have the from our academic health system, Dr. Yulfina, the new stars also now, health stars of the oncology. So we will, Ucha, I would like to, you can share about the what I already prepared. This is some of the gap, the gap of treating the head and neck cancer, because as we know that this is the like I just showed the slide a little bit. Which one? The slide, and we saw that we have like 125 around the participants of the oncology study group, but we only have around 70 the consultant. We have like more than 1,000 ENT specialists all over Indonesia, and then we also have the radiation oncology. Sorry, can you mute? Sorry, can you mute the participant? Please mute the audio. And then this is the distribution of the ENT head and neck oncology consultant in Indonesia. You know, Prof, you can see there is like 5 bigs of the island. And then you can see that more of the consultant is concentrate in the big island, like in the Java. And then there is only one in the Celebes in Kalimantan. And the Sulawesi, we have 4. And then in the Maluku, we don't have it. And then also in the West Papua, I don't have it. And then also East Nusantara. So in Bali, we have 3. And West Nusa Tenggara is already have 3. And then in Sumatra is much, we have more. So it means that the distributions of the consultant treating of the head and neck is not enough. But because of the lack of the training, I think we are start our own training until we got the subspecialty hospital-based training. So this is what we face with the Indonesia. And the other, Ucha, can you change? And then we have a distributions of the radiotherapy access in Indonesia. We can see that there's only a radiation oncology 156, and then the medical oncology 176 for treating 2,070 million first people of Indonesia. I think also we have a distributions of the radiations machine more in Region 3, Jakarta, West Java, and Banten, which is the level 3 is 2D, 3D, IMRT, VNet, rapid arc, helical, and 4D. So the other is the gap that the first I would like to share you. This is the gap beside the human resources and also the facility and also the insurance and also the how the patients face with the cancer, their own cancer itself. Okay, we came with the first cases, and we'll proceed by from the Sriwijaya, yeah, doctor. Yes.
Again.
Okay. Can you start?
Okay, thank you, Dr. Linda.
Yes, thank you so much,
Yes,
Dr. Sugianto.
yes. I'm sorry, I can start share screen. My screen. Okay. Okay. Good afternoon to all panelists and all participants. Thank you. First of all, I would like to say thank you to this opportunity to present our cases from Sriwijaya University, Muhammad Husin General Hospital, Palembang. We start with identity. It is Mr. SJ, male, 60 years old, 46 years old. From analysis, we get the symptom is from October 2022 with a tinnitus on right ear, headaches, and otoroid. So the patient starts seeking treatment to ENT doctor, and medication are given, but there's no further treatment, and also the patient doesn't seek another treatment, and the symptom is remain until May 2023 with additional symptom is epistaxis, runny nose. So the patient is start to seeking treatment again and advises to undergo biopsy, but the patient refuses to take the intervention and doesn't seek any other treatment again. After and on first week of January 2024, the symptom is remain, but there's still another additional symptom with ptosis on left eye, lump in the neck, and weight loss. So the patient taking a decision to seeking treatment to ENT doctor at Pangkal Pinang, which is near on his domicile, and start to taking the biopsy with the result of the histopathological is nasopharyngeal carcinoma. And this patient is referred to our hospital, Muhammad Husin General Hospital on Palembang. But due to administrative issue, so the referral is postponed. On third week of January 2024, the patient came to our hospital, our polyclinic on Muhammad Husin Palembang with another symptom is back pain and weakness on extremity. So we decide to hospitalize this patient and do a further treatment and examination to this patient. This is a histopathological result from Depati Bahrin General Hospital, Pangkal Pinang, with a conclusion is non-keratinizing squamous cell carcinoma, undifferentiated subtype at both nasopharynx. From physical examination, we get on the vital sign is within a normal limit, and on ear examination, we get tympanic membrane central resolution. Left ear is a tympanic membrane bulging, and for a nose examination, we get left and right nose, wide nasal cavity, trophic inferior turbinate, reddish and rough mass seen on the nasopharynx. This is the picture of right and left nasal cavity. We can see there's a reddish and rough mass seen on nasopharynx. For right colli region, there's a solitary knot on level 3 colli region with a size 4 × 3 × 1 centimeter with a solid consistency, diffuse border, and fixated, also with a pain. On the left colli region, there's no neck knot enlargement. From brain CT scan, which is conducted in 19 May 2023 at Siloam Hospital Bangka, there's get a conclusion that a mass on the left side of nasopharynx, which is infiltrate the extension tube, left pharyngeal space, and destroy cranial backbone in the clypeus area and left dominant sphenoid, as well as the tumor is infiltrating intracranially in the area of the sinus cavernosus and left temporal fossa, as you can see on the right. Okay. And this is the nasopharynx CT scan with contrast that we are conducted in on January 2024 at our hospital, Muhammad Husin General Hospital Palembang, with a conclusion or with a interpretation that left dominant nasopharyngeal mass obliterating the left racemolar and left thorax tuberous. Also, the mass is already infiltrating the left medial and lateral pterygoid muscle and extension to oropharynx, bilateral guana, bilateral sphenoid, and also left posterior ethmoid. And the mass is already also infiltrating intracranially to the left temporal fossa, as you can see on the red circle. We also conduct abdominal ultrasound on January 2024, and we get an interpretation that there's multiple metastatic nodules with a larger size, 3.97 centimeter, 3.9 centimeter in the liver. And also on the bone survey that we conduct on 26 January 2024 at Muhammad Husin General Hospital Palembang, we get interpretation that osteolytic lesion on the pubis bone, and we suspect it is a metastasis process to the bone. From anamnesis and examination that were conducted, we assess this patient with WHO type 2 nasopharyngeal carcinoma with a 4B stadium, and TNM stadium is T4N1M1 with a bone and liver metastasis ECOG3. So what's the problem of these cases? That the patient is already come to us with an advanced medical condition, or the late stadium, it's a 4B stadium with a metastasis to the bone and to the liver. And also, actually, patient is already educated by ENT doctor about biopsy intervention, but the patient is declined for that intervention. Is it there's maybe because of the patient is not understand about this intervention, or maybe the medical crew who explain about this intervention doesn't give the education enough for the patient, so the patient doesn't know about this intervention and about his illness. And also one of the factor that made this patient cannot came in the early stage of his illness is distant from his domicile to advanced medical facility. Maybe this is the problem of this patient. So he cannot take the early stage treatment and also diagnostic. If we can take this problem, maybe we can close the care gap of the patient, like a motto that we already have for World Cancer Day today. That's all. Thank you.
Thank you, Dr. Sugianto, for the very nice and then clear presentations. But I'm a little against with the problem of number second. Because of what? Let's see what's happened with the patients. The patients is already came October 22nd. And then he came to the maybe several ENT doctors, but he still complained with a tinnitus, headache, otore. And then again, he came to the May 23rd. Again, he came to your institutions, the January 24th. Oh yeah, I forgot that I also have supervisors of these centers, Dr. Eriza. Welcome, Dr. Eriza, and also supervisors, my friends, Dr. Gede from Bali. So I will ask you later a question as well. Do not stay there. But see, I would like to ask the boss of the residence first, Dr. Ria. Let us see about this October 21st, and then the patients came with the tinnitus. We have to care about the early signs of something. So with the tinnitus, with the headache, with the otore, should the persons, we as a doctor, suspect with the differential diagnose as a ENT? What do you think, Dr. Ria?
Yeah, I don't know about the age of this patient.
40, 46,
46. Okay.
and still young.
Still young. Yeah, if you have a persistent complex symptoms like headache, otore, epistaxis, runny nose, then you have to have a different diagnosis more seriously. So I noticed there is a lack of time from the May 2023 and then first week of January 24. What happened on the 23 May till January 2024?
Oh, you asked Dr. Sugiarto?
Yeah.
No.
Okay. Actually, this patient is go to another center of the hospital. It doesn't come to our center. So we by the analysis that we conducted, he just doesn't want to try the treatment and the biopsy that already recommended by the doctor that who
From your center.
recommended it.
Yeah. Okay. So, sorry, Dr. Malinda, and what is your question?
Yeah, I think because this is the long way to go. And then the October 2022, and the patient is already like a complaint about the specific things. And then do we, as I don't know whether in the October 2022, the doctors just examine the ENT examination, or should they already do the like endoscopy or something, or imaging, something like that?
Yeah, of course, there is a delay of treatment here, Dr. Malinda. And the delay of treatments can be a result of multi-factor. It can be from the person itself, the patient itself. They are reluctant or very afraid to hear about biopsy, or maybe they have also difficulty using our national insurance, or there is other external factors the doctor did not give a very thorough education for the patient, but this could be serious. Maybe the institution or hospital itself doesn't have the means, doesn't have the and of course, but not least, I think because the a lot of patient, that means there is a long queue up. As you know that in our institution itself, to have a CT scan, sometimes you need about 4 weeks to 6 weeks to have your CT scan done. So there is a lot of factor, Dr. Malinda, and I think this is causing the gap, if you are going to mention that. So we have to discuss about how do we close this gap, right? One,
Yes.
of course, we have, for the residents especially, we really have to sharpen our clinical diagnosis, clinical evaluation.
Kalau yang Prof ngomong usia anak-anak sama dewasa.
Hello.
Yeah, I think because sometimes we have the luxuries of having an endoscope, the luxurious using a CT scan, then we have don't have the skill anymore to perform a very sharp clinical diagnosis using a basic instrument. So I think that's why sometimes we still have to teach our residents the skill using a mirror for posterior rhinoscopy. It doesn't mean that we are going to go back 50 years behind, but we do know that in some center that they are going to be assigned to, there is no endoscope. That means, are they going to are they not equipped to perform their knowledge? So this is why our collegium is very taking it serious for the resident to have the skill, a standard skill, the basic skill before they are skillful using the endoscope, using the the USG or even the MRI. I think that's Linda.
Yeah, thank you, Dr. Ria. I admit your, and then I agree with you that we have to bring the residents to use the ordinary things. Doesn't mean that we are a few years behind. So yeah, I agree. But thank you, Dr. Ria, for your opinion. But I would like to ask now the Dr. Professor Muhtarum Yusuf. So when the patient came with you in October 2022, what are you going to do with this? With the tinnitus, the headache, the otore? Such as you have a fancy thing. You have a posterior rhinoscopy, but you also have the endoscopy, even the rigid or the should we think about other disease that seriously not only give the medication? How about the Professor Yusuf?
Okay, thank you, Dr. Marlinda. I think the sign of the patient in October 22, yeah. I think three signs. There is a tinnitus, headache, and otore, special for NPC. So I would like to explore more with nasal endoscopy. After that, we do the biopsy. I think enough for the case. Yeah.
So okay, thank you, Prof. Yusuf. So you already think about there is something seriously beside only the problem of the otore or the tinnitus or something. You are thinking about the I think
yes,
that
serious disease there.
Okay.
The first diagnosis is the NPC, because the three signs, tinnitus, headache, and otore, one side.
Okay. Yeah, I'm agree with you. So this is the I think from Dr. Iria, and then again convinced by Professor Yusuf that we have to skilled or the clinical appearance of the sharp diagnosis of the patients. So and forget, and not only the epistaxis, for the NPC. So I would like to ask Dr. Yuli. Yuli, when you will do, this is the long of time, yeah, October 22, 2 years, almost 2 years, 1.5. So when did you do the imaging of the patient? Because yeah.
Yes, thank you, Dr. Linda. I also agree with Professor Yusuf and Dr. Ria and the presentation that is the patient and the delay on diagnosis. So in my opinion, the first time when the patient came with these symptoms, we have to do the endoscopic first. As you know that in my hospital, I have the tool like endoscopic, I have a rigid, I have a rigid and flexible endoscopic. So every patient that came first time, we should evaluate the nose, the throat, and also ear of this patient. And after that, if I saw the patient with the mass in the nasopharynx, then I do the imaging immediately, not waiting for the other symptom to continue. Then doing the radiology examination. So the first thing is what I want to do is the endoscopy first.
Okay, thank you so much. So the endoscopy is done in the, I think, in the other hospital, maybe in the week of January 2024. I would like to ask Professor Busso, what is your opinion about this case? Because the male, the productive ages, and then he refused of the procedures. But what is your side to see these patients?
Well, of course, it's a sad story because nasopharyngeal cancer is a highly curable disease, and usually also the quality of life after treatment is quite acceptable. In this case, of course, with distant metastasis and massive intracranial invasion, the possibility to cure the patient is almost zero. Of course, you may not feel confident in recommending local treatment, but only systemic treatments. Of course, the problem is probably the late diagnosis. I mean, 1.5 years is not very much for a nasopharyngeal, but still it's a virus-driven disease. So it's highly probable that in October 2022, distant metastases weren't there, and for sure, intracranial invasion wasn't there. I completely, of course, it's a cancer care gap. It's a clear example of cancer care gap, because if it was, if he had been able to undergo immediately a complete evaluation with a biopsy, it would have been his prognosis would have been drastically different. Yet, I would like to outline what has been said by Professor Trimartani, because it's something I always tell my residents as well. You need to understand what's going on, and the mirror is the traditional, very effective tool in the hands of our specialty. So probably if the first doctor in October 2022 would have the curiosity, even without nothing, I think everybody has a mirror in his office, the curiosity to see what was behind, and the fun to check the nasopharynx, probably it could have been recommended the biopsy. I did in the beginning of my career, I did a lot of nasopharyngeal biopsy just with the mirror and with the Nelaton and under local anesthesia. So, I mean, you don't need, and that's something about closing the care gaps. So doing the best with what you have. So in theory, exactly as you just need the knife and speech therapist to do supraclavicular laryngectomies, you just need a mirror, Nelaton, to diagnose a nasopharyngeal cancer. So it's very, very important to remind our residents that they have a mission, that's their job, and they are everybody is good to do it with the general anesthesia, rigid endoscopy, and CT scan, MRI, but to be able to take the patient in 5 minutes, doing the posterior rhinoscopy, putting the Nelaton, pulling the soft palate, doing the biopsy, well, then you are good. So look for your confidence. And I can tell, I don't have big experience with I saw many, of course, along years, nasopharyngeal cancer, but you have a huge number of these cases. I think your area is one of the highest incidents in the world. But I have, for sure, much more experience with laryngeal cancer than with nasopharyngeal. And I can tell you, the mirror gives you a view of the larynx, and you have different sensations which integrate your endoscopy. So it's not only a matter of being able to do things with different means, but it's also a matter of getting other data to correctly assess and manage your patient. So sad story. And that's one of the cases we don't want to see if we close the care gap.
Okay, thank you very much, Prof. Busu. Quick comment from my colleague from Bali, Pak Gede, Dr. Gede. How did you treat the patients? Because the patients already diagnosed an NPC with the M1, with the metastasis already. So how did you treat the patients? How did you set the informed consent of patients? Just quick answer, Dr. Gede. We proceed with the second quiz.
Thank you, Dr. Malinda. This is both state and terminal state of the patient. The first, we have to palliative treatment for the patient and make mentality patient to grow up the mind of patient to treat the disease. Palliative. Palliative treatment, Dr. Malinda.
Yeah, okay. Thank you, Dr. Gede. I think I will conclude this with this first case with this T4. I think T4N1, yeah, I'm not mistaken. And that in the NCCN, there are two options. Either we can go on, we can treat the patients with the chemotherapy, full dose, or we can proceed with the chemoradiations. And after that, we can give the chemotherapy. So this is the options. But I think we have to tell honestly, like Professor Busu said, that talk honestly to the patient, the possibility of recurrence of the patient, or the palliative, that we not only treat the not for the curative indications, but also to palliative, to make the quality of life of the patient is good. Remember that the patient is male, like you always get the NPC patient, the male mostly, but this is the productive ages. He got already the metastasis in the bone itself. So be careful that we have to treat also the comprehensive, that we have to maybe for the weight-bearing bone, for the bone, so we have to treat it with the radiations to avoid the fracture, the pathological fractures. So first we have to treat the patients palliative with either with the chemo, with the radiation, with chemo radiations, and then informed consent the patients. But I would like to state what we discussed with Professor Bambang, and then because he is the one that the medical students is if we came to our division or in the polyclinic, and then they wrote the examinations of the endoscopy. So Professor Bambang said, did not treat or taught them the posterior rhinoscopy. So this is the important thing. We are the referral hospital. We have a endoscopy, but never forget to teach the students, the young one, to use the ordinary or the examinations that you have, like Dr. Ria said, the posterior rhinoscopy. So they have to really know how to do it. So I think I think we can proceed with the. Is there any comment from other panelists before I proceed with the second case? No? Dr. Eriza, no? You are the Prof. Buso, you would like to say something? No.
No,
okay.
you told everything. I completely agree.
No. Dr. Eriza, you would like to add something? You are you have the patience?
Yeah, thank you, Dr. Marlinda, and all panelists. I agree because not all regions have endoscopic facilities, so we must have sharp critical clearance and sharp examination with the basic examination, so we can treatment the patient like Prof. Bushu say, even we lack of facility, we must keep doing, keep working. So maybe patient not come with the advanced stage of the cancer. Thank you, Dr. Marlinda.
Yeah, thank you. Because the early stage, we can treat the patients the most the good prognosis that we can get. Okay, so we thank you very much for all the panelists. So we go to the second case from the Bali. Bali or what? Oh yes, Bali. Welcome,
Good
Dr. Felicia.
Doctor. Thank you, Doctor, for the opportunity. If I may share my screen and presentation. So I am Yumi, an ENT resident that will be presenting Udayana University to present our case. Thank you for giving us the opportunity. This case will be about tongue squamous cell carcinoma and how we manage it in our institution. The patient is a female, 60 years old, that came to the ENT clinic with a chief complaint of a lump on the tongue that has only been felt since 1 month ago. The lump slowly increased in size and became painful, radiating to the right half of her head. And she also felt a numbing sensation and difficulty moving her tongue, causing mumbled voice, hypersalivation, and difficulty swallowing. But it did not hinder her to swallow food. There was no shortness of breath or lump on the neck, and the patient had a history of recurrent tongue ulcers for many, many years, sometimes accompanied by lip swelling, and those symptoms usually subsides by its own. Usually people in Indonesia likes to chew betel nut, which was said to be good for teeth and oral health, but this patient did not consume any betel nut and did not smoke nor drink, only had a recurrent tongue ulcers. And a little bit about the background of the patient. She lived in seashore near the beach, which there's a lot of sun exposure that may contribute to the development of the tongue carcinoma. The history of illness of the patient, there's no history of carcinomas, only had controlled hypertension with amlodipine and no operation history before and no family history of cancer. From the vital sign, there's only a little bit elevated. From the ENT examination, the ear and nose appears to be normal, but the oral cavity, there was an irregular mass on the right side of the tongue, approximately 4 times 2 to 2 centimeter in size, which on palpation, she felt painful, it's fixed and hard on palpation. There was no enlargement, no lymph node enlargement. And after we did the biopsy, the results are well-differentiated keratinizing squamous cell carcinoma. Here's the tongue CT scan with contrast that showed heterogeneous solid mass with irregular shape and their central necrotic area in the anterior to posterior body of the right tongue. The size is about 4.6 times 2 and 3 centimeters in depth. This infiltrate both the extrinsic and intrinsic muscle of the tongue. And there was also multiple suspicious lymphadenopathy. The laboratory results normal in this patient. Then we did other supporting examinations from chest X-ray and liver ultrasound. There's no abnormalities. And for the bone metastasis, we conducted bone survey that showed multiple osteolytic lesions on the skull and bilateral proximal and distal third of humerus that suggest metastatic bone disease. Therefore, we diagnosed the patient with a tongue squamous cell carcinoma stage 4C with T4A and 2C and M1 with bone metastasis. The patient undergo chemotherapy with Brexaline carboplatin and targeted chemotherapy along with Bonjournet chemotherapy. Afterwards, we planned for the operation using combined mandibulectomy and neck dissection or commando procedure with a pectoralis major myocutaneous flap. Here is the procedure that we did. We first did the modified radical neck dissection on the right side. We take the lymph node, the 1 to level 5, and then we did mandibulotomy, which then give access to subtotal glossectomy. Then we harvest the pectoralis major myocutaneous flap. Sorry, there's no video for this, but the flap was then raised from the pectoralis major up into the oral cavity. We inserted and then we close the mandible using plate and screw and then sutures the skin. This is the follow-up 1 day post-operation. Then this is the follow-up 7 days post-operation. The post-operative suture seems to be healing well. And this is the follow-up 2 months post-operation on the tongue of the patient. We see that the flap and the original tongue from the left side is closing nicely. We keep the sutures for a longer period of time to prevent the separation of the tongue. And post-operatively, the patient reported reduced hypersalivation and no pain on the right side of the face. And there was improvement of the voice, although still a bit mumbled. And still, the patient is still learning to move the tongue. The patient is currently planned for radiotherapy and still waiting for her turn. The histological study of the resected tongue showed clean margin and no lymph node metastasis. Thank you.
Yeah. Thank you so much. Congratulations, you did a good job, the teams of the Bali, and then you did the commando procedures, which is a quite extensive procedure for the oral cavity cancer. So the combined, we call it the combined mandibulectomy and neck dissections operations. And then I would like to, I don't want to discuss about the procedures. I'm interested with the close the care gap, because the patients again came with the advanced stage. So Professor Busu, I would like to ask you, how did you do the awareness? How did you do the early detections of the oral cavity cancer in your institutions?
Oral cavity as hypopharynx and as non-HPV related oropharyngeal cancer are usually the patients nobody wants. So that's a big problem, because in these cases, well, this lady is a particular situation. From the story, I don't know which is the prevalence in Indonesia of lichen rubber planus, of lichenoid lesions. The story of recurrent ulcers in the mouth brings me to think that this lady probably had a lichen, and finally the lichen became cancer, which is a very common situation in patients with lichen. So these patients have recurrent ulcers in the mouth, and sometimes also in the lip. And in fact, the lady reported to have common swelling in the lips. So this lady probably was really not a smoker, not a better good chewer, not a drinker. And in this case, it would have been very difficult, because I have cases of lichen I follow for a long time. I try steroids, I try even targeted therapies. At the end, after many years, they develop oral cavity cancer. But most of the patients with oral cavity cancer, like this, with hypopharyngeal cancers, like the one I've shown, with the non-HPV related oropharyngeal cancer, they are drinkers, they are smokers, they don't come to the doctor, they keep drinking and smoking after surgery, after treatment for their tumors. And in these cases, closing the care gap is a gap between people without this low socioeconomical status, these bad attitudes, and those who are able to better behave and better manage their behavior and their behavioral risk factors. So it comes to social aspects. We need to be inclusive with people to avoid the margination, to obtain a lower incidence and earlier diagnosis of this kind of cancer in general. That's the most important issue. And of course, it's not easy. It's not easy.
Sorry, Prof. Busu.
So
how did you do the early detections? That's you do what did you do? Like every ulcer for more than 2 weeks. 2 weeks. Hello, sorry. Can you mute? Yeah, Prof. Busu, how did you do the early detections for the oral cavity, like the lesion with the lichen planus of the ulcer more than 2 weeks?
That's a big problem. The lichen planus is really a big problem, because they keep developing these recurrent lesions, and you will be tempted to do biopsy every time, because in a patient without a lichen rubber planus, a lesion with this with that appearance would have been highly suspicious. But then with lichen rubber planus, you may do like 5, 10 biopsies along years, and finally, without any let's say any clue why, the 11th biopsy it's cancer. So it's really the worst situation, I think, in oral cavity, in oral oncology. But in the other cases, usually you look, the problem is to make the difference between ulcer and cancer. So my suggestion is always easier and cheaper is better. So the palpation,
Okay.
we've seen the CT scan.
Yeah.
And so apart from inspection, the palpation. So you see the ulcer, you see the aspect of the tank, but you need to palpate it. If it's hard, especially in the peripheral part of the ulcer, then it's highly suspicious. If you find a hard cord around, then it's highly suspicious. And for sure, you need to do a biopsy. If it doesn't solve in 2 weeks, then you need to do the biopsy.
Okay. Thank you so much.
The palpation and the cheap tools, the tumor was larger than what's in the CT scan. So that's typical, and that's very tricky with the oral cavity cancer. If you don't have a good radiologist trained in MRI, if you don't have access in MRI, which is the most effective modality for classification for staging the primary lesion in oral cavity, then your finger is more sensitive than CT scan.
Okay.
In assessing also the overcoming of the midline. That's
Okay.
my experience.
Yeah, thank you, Prof. Busul. So I would like to go to Surabaya. How did you manage these patients? And then are you going, which one do you choose before the biopsy, like after the palpation, you are suspect of something? Are you going to do the CT scan or the MRI? We know that not everywhere have a MRI, but what did you choose, Professor Muhtarum?
For this case.
Yes, of course. I'm talking with this case.
We do CT scan first, because I would like to know there is infiltration in mandibular to know the infiltrate the mandibular. After that we do the MRI to know how the diameter of the tumor. Yeah. After that, the next minute, I agree with the colleague from Bali. Yeah. Neoadjuvant chemotherapy, targeted therapy. After that, we do the commando operation. After that, they find the sign of the residual tumor, microscopic or margin tumor still the tumor. I gave the adjuvant chemoradiation.
Okay, thank you, Prof. Muhtarum.
Yes.
I came back to Dr. Yuli. I know that you are working also in the Jakarta, and then you have a fancy CT, MRI, but we don't have a PET CT. In your hand, what did you choose for the oral cavity?
Thank you, Dr. Linda. I will choose the MRI because it is best for the soft tissue tumor. So I will choose the MRI compared to the CT scan. But CT scan is also good to see the infection to the bone. But if you know that money is a problem for treating the patient, so if you want to choose one, I'll choose the MRI for the patient. That's the first one. The second one, for the treatment of this patient, I agree with Prof. Muhtarum. I agree with the presentant here that the treatment for the patient with initial metastasis, for the patient, we can go for the chemotherapy, for the clinical trial, or you can do the surgery followed by the combination of systemic therapy. But the most important thing is we treat the patient as the patient. We not treat only the disease. I mean, when the patient with metastatic bone metastatic, the treatment is palliative treatment. So we have to tell the patient and family that the treatment that we give are to improve the quality of life of this patient. That's from me, Dr. Linda.
Okay, thank you so much. But I think I would, yeah, thank you. I would like to add that because yes, you're right that I agree with you that because we cannot like the fancy, because I know that Francisco said, oh, we can do, and also in the we can do the CT and also MRI and then both. But we have the gap, so we have to choose which one is the best. But I think for the oral cavity, and then we can extend the tumors, and then the most important thing, we can evaluate the depth of invasions, because the depth of invasion is the one of the prognostic that involved in the staging. So I think that is so. But if we, like Dr. Prof. Mokhtarim Yusuf said, that maybe we're suspicious about the bone involvement, then we can also ask for the CT. But MRI, we have a long QE. Are there
Dr.
any?
Linda?
Yes.
Dr. Linda, may I add something? If
Yes.
the patient have an indication for surgery, I do believe that this patient cannot be postponed for the long time. You know, the QE is the problem for us in Indonesia. The QE is until 3 months. For the patient with the oral cavity cancer, the tongue cancer, I believe that we cannot postpone. If the patient is in the resectable disease, so you have to do immediately, not too long from the MRI. I think that.
Yes. Yes, I agree. I know that you are already raised your hand, Professor Busso. Time you can talk.
Just a quick comment.
Yes.
Just a quick comment. I told the residents to be always critical. I don't know, of course, I haven't seen the paperwork and the images. I will say that we are saying that this patient is M1 for bone metastasis. The probability of oral cavity cancer, primary oral cavity cancer, even with N2C neck, to have distant metastasis to the bone is very, very low. So my suggestion, always never be sure, always ask questions, always have doubts. So before saying that's M1, I would at least ask it for a bone scintigraphy in this case. I don't know if he did, but otherwise, considering the fact that the probability of bone metastasis in such a case is very low, before giving it as an M1, so let's say a desperate case, I would at least ask for a scintigraphy and even maybe to a bone biopsy. Second thing, again, to close the care gap, I see that the big advantage of CT scan, especially if you don't have the MRI, so you do CT scan, you assess the primary lesion with palpation, but you do the CT scan also to the lung, because all of the neck cancer patients, especially smokers, especially larynx, especially oral cavity and oropharynx and hypopharynx, they have a high rate of second primary tumors in the lungs. So being able to detect early the second primary in the lungs will save them their lives. So in my clinical practice, I learned to do always, when staging an head and neck cancer, a chest CT scan, not to looking for metastasis because they are highly unlikely, but to look for second primary tumors. This way, we will get the lung cancer very early, and it is, in these cases, it's highly curable. That's my suggestion.
Yeah, that's a good point, Prof. So we have to think about the second primary, the second primary tumors, yeah, because yeah, I agree with you. So are there any suggestions, Dr. Ria, maybe, or Dr. Eriza, or Dr. Gede? Do you have any comment?
Yeah. Yeah, I think tongue cancer is one of the cancer that is very vascularized, right? And then I do believe that communication is the essence of treating oral cancer. Ulcer on the tongue usually in people in our people related to deficiency of vitamins or trauma. So they don't realize that it could be cancer. So again, promotion, education, preventive from our primary care should be more the patient itself. Because once we have an oral cancer or tongue cancer, then you have to make a diagnosis more thoroughly, not just to look for metastasis. As Professor Bosu mentioned, maybe a secondary primary as well. So this is should be communicate to the patient, and then to, of course, to our general practitioner who are on the frontliner. And then, of course, we have to really select the modality of diagnosis, whether using a CT scan or MRI, because this equipment is not available in every hospital. We do have a luxurious of using a CT scan, but not an MRI. The government is now building a hub for this referral hospital, 2 big hospitals in Makassar and also in Surabaya, I think, to catch all the referral cases from the Makassar, Papua, and then from the Nusa Tenggara, Bali as well to Surabaya. But I think even though the government have a huge hospital, which consists of 800 beds, specially equipped with radiotherapy itself, I think the best treatment is preventive, Dr. Malinda, and of course communication.
Yeah.
Thank you.
Yeah, thank you, Dr. Yeah, it's a good site for this for our talk today. So I would like to ask, are there any suggestions, Dr. Gede? You are the one that have patients that you have like a comment, or Eriza? No.
Eriza. Thank you, Dr. Malinda. This is a good patient because we received the patient with bone metastasis and late stage. We have do chemotherapy, targeting therapy, and targeting with Bondrona therapy to solve the bone metastasis. And after chemotherapy, before radiotherapy, we bargain to the patient because the patient still feel so pain and cannot swallowing. We suggest the patient to operate, and the patient agree to operation. After operation, we will plan again to radiotherapy this patient. After operation, the patient feel better with no pain and can learn to swallow. But until now, the patient still using NGT, nasogastric tube, and combine feeding with enteral and oral nutrition. Thank you, Dr. Malinda.
Okay, thank you, Dr. Gede. So I will before I close this second case, I would like to give the important things that Professor Busso said about the important things about the palpation. The palpation can revert maybe a little bit for the beginning, for the needs of the CT scans, about because of where with the palpation we can evaluate how the extensions of the lesions and then and the heart or the painful, and because the oral cavity sign is the painful mass. That is always think about it. And then use the CT scan for the especially for the advanced cases with the T4 and 3 because of this possibility of the second primary tumors. And I think, the important thing is the known about the clinical sign and do the physical examinations. The good important is just not only just do it, but also do it right. Then you compile Nike, Reebok, Under Armour, Lululemon, because the Nike said that just do it. No, not trust with the Nike. Use the compile of the Under Armour, Lululemon, Reebok, Adidas, whatever. Okay, I closed the second round of the cases with the interesting cases. Thank you, Dr. Gede, that you did a good job with the patients. And hopefully that she got right away the radiation post-op. And then you have to control all the possibility of the recurrences. So what is the third case? Dr. Prof. Buso, I hope that you are still with us and then still...
Absolutely, my family is sleeping, so I'm completely with you.
Thank you, sir. Thank you, Prof. Okay, Dr. Denisa, please. Yes, Denisa, you can start. One, two, three.
Overtime.
Overtime. Yes. Do you have a problem, Dr. Denisa?
Mbak. Sorry, doctor, please wait.
We are
Tadi
still...
sudah kelihatan tadi.
Do you need help in sharing? Because I also get the PowerPoint from Dr. Yoga, Dr. Denisa.
Yeah, I think you can share, Icha. They're just for the keeping the time. Yes.
Okay, thank you, doctor. Good afternoon. Thank you very much for the opportunity to present a case from Dr. Sutomo Hospital, Surabaya, Indonesia. Today, we are going to present a case of a 10-year-old boy with a recidive juvenile nasopharyngeal angiofibroma. Child MRM, 10-year-old boy currently living in Situbondo, East Java, about 5 to 6 hours away from Surabaya, and is a student. Patient came to ORLHNS Oncology Outpatient Clinic with chief complaint of protruded right eye since 6 months ago, along with painful lump on the palate 6 months ago, bilateral nasal blockage 5 months ago, and other complaints such as episodic massive nosebleeds, intermittent mucoid nasal discharge, snoring, difficulty of speaking, headache and facial pain, shortness of breath, and right-sided hearing impairment. Previously, in 2022, the patient came to the clinic with similar complaints and assessed with stage 3B juvenile nasopharyngeal angiofibroma. The patient underwent his first preoperative vascular embolization in June, and then second embolization and preemptive tracheostomy in October, and JNA extraction in November with transnasal approach, with history of blood loss of 6 liters and then return to spontaneous circulation, and approximately 90% of the mass was extracted. Ears and neck are within normal limits. Anterior rhinoscopy demonstrated a friable reddish mass within both nasal cavities, fixed firm friable reddish mass on the hard palate with isthmus fotium about 50%, and from facial region there was proptosis and conjunctival chemosis, protruded right eyes, and bulging cheek. Contrast enhanced head CT angiography on January 2024 demonstrated a solid hypervascular ill-defined mass that is expanding to right and left sphenoid frontal and ethmoid sinuses, infiltrating intracranially to the right temporal lobe, right cavernous sinus, encasing right internal carotid artery, infiltrating right orbital cavity, medial and inferior rectus muscles of the eye, compressing the optic nerve superiorly, expanding to the right infratemporal fossa, obliterating Rosenmuller fossa, torus tubarius, and both eustachian tubes, and obstructing the entire nasopharynx to the palate. So now we are going to discuss the several problems arising from this case. The first problem is that the disease, lack of awareness from the patient and the family. So we need to remember that this is not the first time that the patient came to our clinic with the advanced staging. This is the second time, and we think that there is a possibility that the family only pay attention to the information we gave that this disease is of the benign kind, but not really pay attention that this disease is a very progressive one. Also, in addition to it, the residence location of the patient, which is about 5 to 6 hours from the city, also make the patient not able to come regularly to have his follow-up care to our hospital, and also increase their daily expenses. So the next problem is about the disease progressivity caused by the residual mass from the first surgery, the history of massive blood loss during the surgery. We believe that we need preoperative vascular embolization and external carotid artery ligation before the surgery. And in this, in the case of residual stage 3B juvenile nasopharyngeal angiofibroma, we believe that this needs a multidisciplinary team approach that involve neurosurgeon, ophthalmologist, radiology interventionist, anesthesiologist, and pediatricians, because the lesion is not only limited to nasopharynx region, but also have expanded to the brain and the eyes. The next problem is the postoperative defects that needs to be discussed and solved, considering the current condition of the patient. The last but not the least, in fact, probably the most important issue here is the postoperative follow-up. So when the patient came to our hospital for a follow-up care, we see the need of an immediate CT scan evaluation, also for planning for the next surgery. So that was what we did immediately. We sent the patient to have a CT scan, but unfortunately here the patient need to wait for about 2 months until he get his surgeons to have the CT scan. So we think that 2 years of 2 months of gap is enough time for the mass to grow progressively and cause the enormous harm to the patient. So I think that's all today from Surabaya. Your precious advices and thoughts, considerations are very welcome. Thank you very much.
Thank you, Dr. Denisa, for the very interesting case. So I remember when Professor Myers came to Jakarta, and then I invited him to attend our cancer meeting regularly every Wednesday. So every cases, all the advanced cases. So he said to me, Marlinda, can you give the tiny cases of the cancer? I said, so this is what we face, Professor Busu. All the 3 cases is most of the cases are the advanced cases, and then of course there's a neglected patient. So I don't want to talk a lot, but I would like to ask the opinion of this case from Dr. Eriza from Palembang. Eriza, are you there?
I think Dr. Eriza asking to leave because she has another schedule for.
Oh, okay. I asked Dr. siapa? Yuli. Yuli,
Thank
what?
you, Dr. Rida.
What is
Thank you,
your comment?
Dr. Rida. This really big mess for angiofibroma. The first one, maybe if the patient came to me, I would like to evaluation for histopathology. Is this really juvenile angiofibroma or anything else? So I have to discuss it, and I will make a meeting with a neurosurgeon, with the histopathologic, also with radiology intervention to do what the best for the patient. Second one, because the patient already have a surgery, I would like to do MRI to know the invasion of the tumor, and then evaluate from what the treatment based on the histopathologic and also from the radiologic. That's if it is really angiofibroma, I think we have another treatment. I think this really big maze to do a surgery, and the risk is very big for losing the patient in the intraoperative. So if you want to do a surgery, so it's really based on the best treatment. I mean, if we can do the radiotherapy before or the hormonal therapy first, then we continue with the other treatments such as surgery. Surgery is very risky for this patient, I think, Dr. Marlinda.
Yeah, thank you, Dr. Yuli, for your opinion. I a little bit agree. I mostly agree with you, but I would like to hear the comment from Professor Busu. What about if the patient came with Sasari? What are you going to do?
It's going to be very hard to approach it, Sasari, but I think everywhere in the world. First, we need to really check if it's true that the internal carotid is encased, because we need an MRI for sure to exactly define the resectability of the lesion. So, of course, if the internal carotid is completely encased by the tumor, everywhere we question the resectability, and we have no other option than what Julvina is suggesting. If it's resectable, of course, it's anyway extremely risky procedure. We love endoscopic approaches, but in this case, I don't see it feasible at all. Probably I see feasible a combined approach, because let's say feeding of this lesion, if it remains the classic one coming from the sphenopalatine artery and from the internal maxillary, probably an endoscopic let's say, support would help to reach earlier the vascular supply and try to cut it off. But still, we are really talking about an extreme case, and we need, of course, the neurosurgeon. We need the ophthalmologist. Difficult. We need a lot of more data to be able to say something, even to say if it's resectable. And actually, coming back to my suggestion and our suggestion to be always critical and to question and not to take for granted all the information, first thing for sure is going to be the review of the histopathology. So I completely agree with you, Elvina, because I've never seen such a, I've seen huge angiofibromas, but never seen one such angiofibroma. So big, so quick growth, and so quick recurrence, because it's only a few years after the primary resection, and now we have this situation. So, and in a place where we have a lot of nasopharyngeal cancer, if I see this patient for the first time without having information about the previous current histology, I would think about a nasopharyngeal carcinoma, actually.
Okay, thank you, Prof. Busso.
And also 10 years. How old is he? 10 years, right?
Yes, 10 years, small child.
Too young.
Too young. Yeah.
Too young. While we see nasopharyngeal carcinomas in this age, we don't see usually angiofibromas. Usually are at least 11 or 12, and that's already a recurrence.
Yes.
At least 11 or 12.
Yeah. Thank you, Prof. Busso. I would like to have a comment from our big lady from the Collegium, Dr. Ria. What do you think about this case?
Yes,
10 years.
happy to see this case, Dr. Malinda. Yeah, I, as a reconstructive surgeon as well, could see the challenge in this patient. But I think correctly, we have not come to terms about the diagnosis, Dr. Malinda, yeah, because this could be a tumor or a vascular tumor, or it could be also a malformation vascular, maybe, I don't know. But it's very huge, and at the age of 10 with this angioma, I think we need to do a more thorough investigation on this patient. And then I do agree that this is a multidisciplinary case. We have to sit together with the ophthalmologist, of course, and then of course our neurosurgeon as well. Yeah, back again, is very surprising to see an advanced tumor in Indonesia, right? That means something is wrong with our preventive and promotive, or something wrong with the primary clinics or puskesmas in our nation, or in our country. It should be detected earlier. So everything is, if it's detected earlier, we hope we could give more good prognosis, Dr. Malinda.
Yes. Thank you so much, Dr. Ria. So I will have a little bit comment from the supervisor that have this wow diagnosis of tumor. Dr. Prof. Yusuf.
Yes, thank you, Dr. Malinda. The final diagnosis from the histopathologic result is the angiofibrom, according to angiofibrom nasopharynx, not cancer or else. Yeah. So we plan the reoperation result from the multidiscipline discussion. Neurosurgeon agree, and ophthalmologic consultant agree with the acceleration orbita and the radiologic intervention agree for the embolization. So the
Yeah.
final result from multidiscipline discussion.
Okay. Thank you so much, Prof. Yusuf. Before I will give the 1 or 2 questions to the residents, because they must be waiting for their time. So I would like to give a comment of these cases, because Prof. Bustu, we have quite a lot of cases with this, because we are the referral hospital as well in Cipto, but we quite have a big tumor like this. But sometimes, first we have to we diagnose based on the clinical, and then from the appearance, and then from the imaging, because mostly when we saw the imaging from the clinical appearance, the mass is like smooth, and then not yellowish, but mostly white, more the hyperemic. And then with this, sometimes there's like also pushing the soft palate down, and then it depends on the extensions. But the most important thing is if we suspicious based on the based on the CT, because mostly because this is the benign lesion, and the border in the CT scan is mostly very good. Then we can divine the border usually, that and then the hypervascularity. But the other is we did we have to evaluate the MRI because of the evaluation of the resectable. But and then I think we have to think about the arteriography to evaluate the feeding artery, but to do the embolizations. But mostly the embolizations is working 24 until 7, and then after the embolization, 24 until 48 or 72 hours, we have to do the extractions. So that's why I really surprised, because this patient had the embolizations on June, the first one, and the second one on October. And then after the June embolization, the patient did not have the surgery. Mostly, we did the arteriography and the embolization is for to prevent the huge bleeding during the surgery. So that's why I don't know why they don't do the surgery after the June embolization. And this the other is Dr. Dinasa or something talk about the ligation external carotid artery. We did the external carotid artery before we do everything, the juvenile angiofibroma, I think 2017 maybe, before we did with the external carotid artery ligations. But they said that we found that with the ligation, there most the possibility of the collateral, and then it must be difficult to do the another embolizations and doing the extractions because of what? Because the collateral. So we are prevent, or we are not used anymore the ligation unless we do during the surgery there's a lot of bleeding, so we can do the ligations, but we take it out again, not for the leaving the ligations. And then and then because of this is huge, maybe it could be gone into the angiosarcoma. I don't know. Yeah, but we know that the angiofibroma is the benign, but in our center, if there is an inoperable case and then the huge bleeding, we can
yang kotor itu Mas taruh dalam plastik.
Hello? Yeah, you can put it in the plastic, but I'm talking now. So please mute the your audio, yeah? Okay, the other is what I'm sampai di mana tadi? What I'm
ligasi carotid arteries, Dok.
Yeah, okay. Like, carotid artery, we do not do anymore because of the collateral. I don't know the comment from Professor Busso later on. But yeah, the most important thing is if the patient, if this angiofibroma, the huge tumor like this, then involve the intracranially on the important structures, we also, the radiation have a place to do even this is the small kids and the benign. So I think that is one. And oh yeah, I'm agree that Professor Busso said that this is a small children, 10 years, and then this is not so common because this is mostly in the juvenile, around 18 until 23 years old. But it's less, we so seldom to find this age. But we know that the less age and the prognosis or the recurrence of the angiofibroma more higher than the advanced age. So I think that is mine. So are there any questions from the students? One or two? We are
Maybe
happy.
I would like to inform Dr. Melinda.
Yes.
We do embolization 2 days before operation.
Huh?
Radiologic intervention perform the embolization 2 days before operation.
Yeah.
Not month, yeah, not month, but 2 days before operation.
Yeah. Okay. Because I saw that in the screen, the June there's embolization, and then October also embolization and tracheostomy, if I'm not mistaken. So 2 times embolization. So that's why I'm asking about the why after the embolization is not proceed with the surgery. So that is so maybe I'm wrong, but maybe the one that make the PowerPoint is also make the mistake.
Yeah.
Okay. Are there any comment? Nope. Are there any comment from Prof. Busso? You are mute, Prof. You are mute.
No, I think we told everything. I'm really curious about the final result. How did it go with the surgery? That's my curiosity. But I don't know if he already was operated or we are waiting for surgery of the recurrence. If I understand properly, they decided at the end to operate in a multidisciplinary approach after embolization. And I don't know, did you already operate on this boy or you are planning to?
Prof. Yusuf,
We
are you planning? You are planning on the process of planning the surgery.
Yes. I already informed concern to his family. Him and his family agree with our plan.
Good luck. Really tricky situation. Yeah.
So Professor Yusuf will send you email about the surgery to you directly.
Thank you. Thank you very much. I will remember the case for sure.
Okay.
Okay. Are there any questions? One question from the residents. I think there is still left 291 participants, the residents or the young ENT specialists. Come on, give a good question or a silly question. There is no silly questions. Everything's good questions. Come on. Hello. Hello. Or they are sleeping. Okay.
And sleepy.
Hello, Dr. Melinda.
Yes. Prof. Bambang.
Yeah,
Prof. Bambang. Nice to have you. Prof.
thank
Bambang
you.
is my senior Prof. Busso.
Okay.
Yeah, thank you, Dr. Melinda.
Nice to meet you.
I have one.
Hi. Oh yes, we met already. Yeah. Hi.
In Bali.
Yeah, in Indonesia. I think the big problem in this patient like this one, not only for the management of treatment, but the problem is why the patient is delay treatment or delay diagnosis or delay maybe from the family or from the hospital or from the other facility of the puskesmas like this one. I think this is the big job from our team, Dr. Marlinda,
Yes, Prof.
to make information about the problem of the head and neck cancer, not where the early diagnosis and early treatment for the next problem about the head and neck cancer. Why the early diagnosis? Why the early treatment, and why the early symptom like this one? Maybe a big job from our team, Dr. Linda.
Thank you, Prof.
This is my
Bambang.
comment. Thank you.
Thank you for the very good side before we closing this sessions. I think Dr. Ya, do you have any comment? No. Yusuf, Prof. Yusuf, Gede
No.
Artika,
No.
Gede Artika. No. Yuli.
Dr. Rina, I think the theme of the head and neck days is fighting with the other who have a power. It means we have to involve our government to have a rule, to have more involvement in this sharing information. So they have to make a rule how to spread information. They have to make a rule for to help us to reduce the gap in the services of the patient to get the care for the patient of the cancer.
Yeah, thank you so much, Yuli. I agree with you. Yeah, because sometimes we have to get more time to give the awareness to the patients, to the mass, to the family. Are there any questions? Are there any comment before I close? Dr. Ya, you are.
Yeah, may I ask some question to Professor Busu?
Yes.
Yeah, as I mentioned in my first talk in the morning, closing the gap is not just our physician part, but also there is a part of our supra system. So in your city, is there a role, or how can we copy or learn or even steal your government program to apply it in Indonesia?
Well, I have to be honest. The Italian system has been probably the best in the world until 1 or 2 decades ago. Now, our countries are not growing under an economical point of view, and they are deciding to cut the expenses in a health system which is more and more demanding. So there is less money and there is more to buy. Think just about the Da Vinci, think about the new accelerators for radiotherapy, think about the new MRI equipment. So I don't think the Italian system is an example now. I think probably you should look at the second post-war period, let's say in the 50s, in the 60s, when after the example of the British system, which was public health, France and Italy built a better system with a very high level of expertise, technology, and a good training, very good training system in the university. So the 3 recipes to improve the health system and to reduce the care gap are, in my opinion, a public system, which can be insurance or different but I mean, I've seen really terrible things in the United States. When I was in New York, I saw a patient waiting in front of the OR. Then he didn't sign the bill, and he was sent out with a big mouth cancer. Okay, so I don't like it as a medical doctor. So I think that the health system must be public, also because it's an investment. If you cure your citizens, you are bringing workers and energies in the society. So it's an investment for the public. Then you can use insurance, you can use public funding, but that's my view. Second, it's the first right of people, because they need to be to have the gap closed. They need to have the best possibilities to survive, especially from cancer. Second, you need to invest on the training system. It must be fair, and it must be well supported, and it must be well organized. And it was true both in France and in Italy in the 60s and in the 70s. And to have money and resources for your health, which is the most important thing, of course, you need to spare on other aspects. So somehow put rules about the private. I don't say you cannot have private health, but you need to make regulations on it, and of course spend less money, for example, in military expenses. So the big problem now in the Western countries is the fast rise in military expenses in the last 2 years, and the reduced financial availability for the health system. So our health system is really definitely becoming worse in the last years, and I don't see currently a concrete possibility of improvement. And in Italy, this is made worse by the fact that there is a big difference between the North and the South, both in the training system and both in the resources available. So I think if you want an example to look at, you are a fastly developing country, you are young people, you are the future, I mean, and we are somehow preparing our grave. And I think you should look at what Italy and France were doing in the 60s, in the 50s and in the 60s. So building a very solid, good and high-level public health system with the support of a very good and solid and high-level training system at the academic level.
Okay.
So don't do like we do now.
Thank you very much, Professor Fusu. Yeah, I think I do agree
Cure
that.
the patient, don't make war. Huh?
Pardon?
Cure your patient, don't make war. That's the message.
Yes, indeed, I agree. We all agree about
Don't
that.
buy guns, buy MRIs.
Right. Thank
Yeah.
you very much, Professor Fusu.
Thank
You're
you.
welcome.
Thank you, Dr. Ria. Thank you, Prof. Buso. I think we have, oh yeah, there is some questions in the question box that Dr. Fadlia, Fadlia maybe from Aceh, from the very north of the Sumatra. And then she asked about what is the, if the patient will do the surgery, what kind of the approach. I think I'm agree with Prof. Mutarum. We are going to do that's better to use the Weber-Ferguson with the subciliary incisions with the eye, because the and then also to the sublabial, because and then we can like open book, and then we can like clean the mess. But yeah, I think we came to the end, but I think I have to make a conclusion of the take-home message. The most important is what everyone said, and Prof. Buso said, that the important is to understand the clinical sign, and then do the right, the proper, the comprehensive, the clinical examinations, and then you do the like the ordinary or simple examinations. Do not only use or trust with the fancy things, but trust your brain, trust your finger, and then trust your heart. And then the most important also do the proper imaging if it's and then give the good informed consent to the patients. But the sometimes the this is show the most advanced cases, the 3 cases, but and sometimes the neglected of the patients. But don't forget the delay that could be came from the patients, because they are neglected, because they don't have any enough educations, they don't have any enough money. But the most important also the neglected from the doctors. The doctors, because of they don't really understand about the clinical sign, they don't really would like to learning. And then this is the most important thing. And then the other is the delay from the system. And because of the systems, we sometimes have to neglect it or wait for the examinations. But the most important thing, like I always said to my oncology training program, and that if we treat something, if we treat the patient, such as the oral cavity cancer, if it's there's no node, and then it's a null, and then we know that the oral cavity cancer, the probability of the to come to the infect to the node is higher than the other side. So treat the neck as well. Because of what? If you already treat the neck, and then we already treat especially of the area that doesn't have any radiations. So we already treat the primary and also treat the neck, and then we already make the possibility of the distant metastasis is less. So that is from. And then the other is I think the other is travel, learn, steal, and bring home. That's why sometimes I like to be the flying doctors, because I always steal and then bring everyone, the colleague to teach in Indonesian colleagues. And okay, I think I already finished with the sessions. As a moderator, I would like to thank Professor Busso. And then this is your daughter?
She's Cecilia. Cecilia.
Cecilia.
Ciao.
Hello.
She's the youngest.
Hello, Cica. Hello. It's a beautiful. Bye. And then thanks from Prof. Busso, and then Prof. Mutarum, Dr. Eliza,
You're welcome.
Ika, and then Dr. Gede and Dr. Eriza that already help us to bring the nice cases. And then I will bring back these sessions to the beautiful moderator, Dr. Ucha.
Yeah. Thank you, Dr. Rina. I think if we can give a big applause to the very outstanding second session. Thank you, moderator and panelists. And next, we will present our token of appreciation for Professor Busso. So I would like to invite Dr. Ria, Dr. Mayang, and please, Dr. Lina, maybe you can present Dr. Angga, because he is having something to do as the head of Indonesian Head and Neck Society DKI Jakarta. So I would like to share the certificate of appreciation for Prof. Busso, and maybe Indra can help to take a picture, because usually we will present it directly to our guest speaker, but due to the distance, so we use the technology. So please, we can take the pictures with the certificate.
Okay, on my marks. Let's wait. Okay, 1, 2, 3, smile, big smile. Sorry, big smile again. Yes, okay.
Thank you.
Okay, and we will send it by email, Prof. Busso. And please, Prof. Busso, if you don't mind, maybe we can take a picture with the oncology division as the committee for this session. So please, Indra, maybe you can help to
conduct and highlight and take the pictures as
Prof.
well.
Bambang, where's Prof. Bambang?
Yeah, Prof. Bambang still here, Dr. Linda.
There's not in the pictures.
Okay.
Ah.
Okay. Please give me big smile. 1, 2, 3. Okay, thank you.
Yeah, thank you very much. So, unfortunately, this is the end of our session today. So, thank you, Professor, doctors, residents, all of the participants for sharing and contributing in this event. So, as all of the speakers mentioned, that we hope that we can do something for this movement and for the sake of our patient. So thank you again for your time and see you in the next sessions and in the next opportunity. Assalamualaikum warahmatullahi wabarakatuh. Thank you.
Waalaikumsalam warahmatullahi
Thank you,
wabarakatuh.
Prof. So, thank you.
Thank you very
Dr.
much.
Thank you. Thank you,
Thank
Professor.
you, Dok.
Kasih semua.
Izin live.
Bye.
Thank
Bye.
you, Prof. Susu. Izin live, Dr. Linda, Prof. Bambang,
you.
Pak Mayang, Dr. Ria.
Ya.
Sama-sama semuanya.
Bye.
Terima kasih, Prof.
Ciao.
Dokter.
The meeting. Thank you, Mayang. Thank you, Prof. Bambang, Indra, Uca,
Terima
Boria.
kasih, Dok.
Bye.
Iya,
Ya.
Ustaz.
Waalaikumsalam.
Terima kasih, Dok.
Ya, terima kasih semuanya. Terima kasih.
Dok.